Welcome to the ISN's Global Kidney Policy Forum. I'm Vivek Jha, the president of the ISN. Dear friends, the COVID-19 statistics hide the tragic loss of many we loved and respected. This number includes the chair of the ISN's Advocacy Working Group, Professor Donald O'Donoghue. Donald was a tireless advocate for the cause of kidney patients in the UK and around the world through his work for the ISN. In honor of his contributions and his lifetime of work, the International Society of Nephrology Global Kidney Policy Forum will be henceforth known as the Professor Donald O'Donoghue Global Kidney Policy Forum. This policy forum's overarching objective is to enable policymakers, patients, clinicians, and administrators and funders to better understand the opportunities to improve kidney health within their regions and propose concrete solutions that will help deliver these goals. This is done by getting high-level decision makers and stakeholders to address the challenges related to kidney disease in a particular country or region and share strategies for the prevention and improved management of the disease, both at regional and at global level. This year's forum, the third in this ongoing series of ISN policy forums, is going to focus on North America and the Caribbean. The unique format will bring an international focus to the key kidney health challenges and opportunities affecting this region. Can you have the next slide, please? On this occasion, I'm also very pleased to release the ISN framework for developing dialysis programs in low-resource settings. Dialysis, this life-saving treatment for patients with kidney failure, but sadly not available to a large number of patients in resource-poor settings. This framework, developed as part of the ISN's program of work with the World Health Organization, has proposed a holistic approach to kidney replacement therapy with an emphasis on shared decision-making between patients and health professionals. The framework focuses on affordability, sustainability, scalability, and equity, as well as provides a resource-sensitive range of options that maintain an acceptable standard of service delivery and encourage stakeholders to develop robust monitoring, evaluation, and reporting tools, which can allow us to track demand, quality, costing, and efficiency of kidney replacement therapy delivery. We hope that this will be used by countries to make decisions on the basis of local evidence on disease burden, costs, and the readiness of the health system to deliver integrated kidney care. We will go straight now into the plenary session of the Global Kidney Policy Forum. I just have one information to share with you. Dr. Richard Horton, the session moderator and editor-in-chief of The Lancet, had to withdraw from the event at extremely late notice. Now, it is my personal pleasure to invite Dr. Soumya Swaminathan to provide the keynote for the forum by telling us about the WHO perspectives on global kidney health issues. Dr. Swaminathan, a pediatrician from India and a globally recognized researcher on tuberculosis and HIV, she brings with her 30 years of experience in clinical care and research and a lifetime of work to translate research into impactful programs in a number of roles. She became the WHO's first chief scientist in March 2019 and heads the science division that was created to strengthen the organization's core scientific work and ensure the quality and consistency of its norms and standards. Before that, she was the Deputy Director General for Programs at the WHO. Her other roles have included holding the position of the Director General of the Indian Council of Medical Research, Director of the National Institute for Research in Tuberculosis in India, and coordinator of the UNICEF UNDP World Bank Special Program for Research and Training in Tropical Diseases. Her group was the first one to scale up the use of molecular diagnostics for TB surveillance and care to understand large field trials of community randomized strategies to deliver TB treatment to underserved population. Dr. Swaminathan, the floor is now yours.
Greetings from the World Health Organization. I'm Soumya Swaminathan. I'm the chief scientist, and it gives me great pleasure to be speaking to you at this Global Kidney Policy Forum at the WCN 21. And thanks to Dr. Vivekanand Jha for having invited me to share my thoughts with you. As you know, we're living in unprecedented times, and we end up talking about COVID-19 almost all the time, and it is occupying all the media space that is out there. But we have to remember that all the other diseases and health conditions that affect people haven't gone anywhere. They're still there, and millions of people suffering from non-communicable diseases, for example, and we need to make sure that the care that they deserve and need is available to them. The WHO did a survey of countries in the middle of last year, July, August 2020. And we found that of the 100 or so countries that came back to us, majority of them were reporting disruptions in essential health services. And some of the services that were most affected were immunization, maternal and child health, non-communicable disease services, dialysis services, tuberculosis and malaria, essential surgery, blood transfusion, cancer care, and of course, rehabilitation, palliation. So these services really took a hit because most health systems just could not cope with COVID-19 and provide the services that they were used to, because they diverted all their manpower and their infrastructure to dealing with COVID. We also saw that the low-income countries suffered much more disruptions in health services than the high-income countries. And so this is really a reminder to us that our health systems are not really resilient, that they're not able to cope with health shocks like COVID, and that in the future, as we plan and strengthen our health services delivery, we really need to focus, first of all, on primary health care as really the bedrock of all health service delivery. We need to make sure that our workforce is not only trained and able to cope, but that there's some resilience in the workforce, that we have some spare capacity. And of course, that we have plans in place, which may include now, using digital tools and technologies and telemedicine and so on, in order to be able to keep up the continuity of health services. Now, coming to chronic kidney disease, I want to say a little bit about the global burden and about, again, the work that WHO has been doing in this space and collaborating with you all over many years. The chronic kidney diseases are obviously an important contributor to both mortality and morbidity from non-communicable diseases. And it's one area where we have not seen reductions in mortality, contrary to other non-communicable diseases like cardiovascular disease, where at least in the upper income countries, you're seeing a consistent decline in mortality. Not true for LMICs and low-income countries, though. The prevalence of CKD and kidney disease failure are increasing all over the world, and therefore the need for dialysis. Unfortunately, the prevalence is increasing most rapidly in low and middle income countries. And in fact, the number of people who may need kidney replacement therapy is projected to go over 5 million by 2030. And the most common kidney replacement therapy is dialysis. What we do observe is great inequities in the provision of these kind of services, particularly in those low-income settings where the growth in kidney failure is the greatest and where there's a huge gap between the total number of patients with kidney failure and the number of patients who have access to these services. So end-stage kidney disease, the global burden is significant. It's also because of the high treatment costs and the impacts on people's health and well-being. There was a recent survey done by the WHO which used the domains of health service delivery and provides a snapshot of the ESKD situation globally. 160 out of the 182 countries that we contacted responded to the survey, and these countries together account for 98% of the world's population. So I'd like to run through some of the findings of the survey, which are in 5 domains from a health systems perspective. The first one is on health financing and service delivery. About half of the countries said that they provide public funding for non-dialysis CKD care. For But again, this is more prevalent in high-income countries. 28% of them charge no fees. Low-income countries, in fact, reported the highest use of private funding for CKD care. Again, 64% of countries provide public funding for dialysis and transplantation. Health workforce, over 70% of countries reported a shortage of nephrologists, mostly in the low-income countries. Worldwide, the median number of nephrologists is about 10 per million population, but the density increases with income. So in low-income countries, you have 0.2 per million population. Lower middle income countries, it's 1.6 nephrologists. In upper middle, it's 10.8 per million population, whereas high income countries have 23 per million population of nephrologists. So that's on the health workforce. Again, you see the same pattern repeated. What about essential medicines and technologies? Again, the availability of chronic peritoneal dialysis and transplantation services increases with income. In 72% of countries that have available dialysis services, at least half of patients with ESKD are able to access dialysis at the onset of kidney failure, but access in low-income countries is only 5%. And among countries that have peritoneal dialysis available, only 4% report that it is their initial treatment for most end-stage kidney disease patients. Chronic hemodialysis services were available in all countries, but chronic peritoneal dialysis services in 76% of countries and kidney transplantation in 74%. But only 23% of low-income countries offered either chronic peritoneal dialysis or kidney transplantation. In fact, kidney transplantation was 0% in low-income countries. In lower middle-income countries, it was 13%, upper middle-income 30%, and 64% of high-income countries said that they offer kidney transplantation. So again, problems with access in most countries. The next domain is health information systems. There were only 13 acute kidney injury registries among the survey countries and 19 non-dialysis CKD registries. 68% of countries did have dialysis registries, and 57% have transplantation registries. They also said, most countries, irrespective of income, that they do screen people with hypertension, with diabetes, with urological conditions, with chronic users of nephrotoxic medications, and people with a family history of chronic kidney disease, that all these categories were screened regularly for chronic kidney disease. The problem, of course, is that these underlying conditions itself are not well documented or diagnosed. So we know that the majority of people living with hypertension, for example, in low middle income countries are not detected to have hypertension. They don't know it. The health system doesn't know it. And even when they are diagnosed with hypertension, they are not on treatment. So a large proportion of this avoidable kidney disease, end-stage kidney disease and kidney failure is because of undiagnosed, untreated hypertension. And in fact, it's estimated that if we can only scale up hypertension diagnosis and management, we would be saving a lot of lives because you would be preventing the secondary complications that we know occur because of untreated hypertension. On the leadership and governance domain, we found in the survey that national strategies for non-communicable diseases existed in 43% of countries. So again, there's quite a big gap. Countries do not even have a national NCD strategy. Another 13% said that they have a strategy under development. And national strategies for improving CKD care existed in 43% of countries. Now, 53 countries, that's about a third, said that they have CKD specific policies. And of these, again, in low income countries, none of them had policies specific to chronic kidney disease, but about half of the high income countries said that they did. And some of them, about a fifth, were standalone strategies just for chronic kidney disease, and another quarter were incorporated into the general NCD management strategies, which is probably the way to go, particularly if we're thinking about a more comprehensive universal healthcare kind of an approach, focusing on primary healthcare. Then I think a comprehensive strategy with elements of prevention, of detection, of management of a variety of non-communicable diseases would be strategic, both in terms of planning for supplies, infrastructure, as well as training of the workforce. So the survey really demonstrated significant inter and intra-regional variability in current capacity to deliver care for end-stage kidney disease. There are obviously important gaps that exist in the availability and affordability of services, of workforce capacity, the characteristics of the end-stage kidney disease care delivery, adoption of different types of health information systems, and strategies and policies. So these findings actually do have a lot of implications for the development of policies for end-stage kidney disease and chronic kidney disease. And to all the policymakers who are listening, I think it is very important that we get an idea in your own countries of the burden of the disease, the risk factors and determinants of disease, the upstream, and also how far is this problem being addressed, what are the gaps, and what are the best ways to fill those gaps. I think efforts should really be directed towards preventing end-stage kidney disease by providing affordable and appropriate care, both for acute kidney injury, for chronic kidney disease, but also, as I said, for the risk factors, particularly hypertension. Increasing universal health coverage for medications in early stage kidney disease is important to slow disease progression and prevent the need for costly therapies which are needed at the end when it becomes an end stage sort of a disease. And also promoting peritoneal dialysis and conservative care as treatment options in situations where hemodialysis may not be appropriate or too expensive, may also enable optimal care. And I remember one of my visits a few years ago to Thailand, where I really got an opportunity to look at the various levels of healthcare delivery. They, of course, have one of the best systems of universal health coverage and primary healthcare that I have seen. And I visited a village where I met an individual who was on peritoneal dialysis at home for the last 6 years with a very good quality of life. He was a farmer. He lived in a very simple home, and his wife and his daughter had been trained to do the peritoneal dialysis. There was a small part of his very modest house that had been sort of made a clean place for this peritoneal dialysis intervention to happen. As I said, the daughter had been trained, the wife as well as the daughter. And this farmer was truly grateful that he had already had 6 years of good quality of life, and he had not had any infections. So it goes to show that it is possible, even in a setting of limited resources or low resources, to be able to do peritoneal dialysis safely and effectively if there is proper planning and training. And again, it could be a much more cost-effective option than setting up many hemodialysis centers, and of course, compared to kidney transplantation. Now, from WHO's perspective, of course, we're very concerned about the inequities in access and the quality of management of kidney failure. And we know that the lack of access to dialysis is an important cause of the increased CKD mortality in low and middle income countries. We also know that the risk factors, hypertension and diabetes that we mentioned, they are increasing in low and middle income countries. And the pressure on the health systems to manage CKD is only going to increase if we don't pay attention to these risk factors now. So the WHO is really pushing in a big way, helping countries and sort of encouraging countries to halt the rise in diabetes and hypertension. We have the WHO Global Diabetes Compact and the WHO Hearts Technical Package, which aim to facilitate both prevention and care of these conditions. We're also working closely with International Society of Nephrology and developing a framework for developing dialysis programs in low resource settings. This framework is due to be launched at the World Congress of Nephrology 2021 It outlines the requirements and operational considerations for setting up or expanding dialysis programs in resource-constrained settings and is intended as a guide to support WHO member states in developing sustainable strategies for the treatment of patients with kidney failure. Advancing the care for patients with CKD is of pivotal importance to achieve the Sustainable Development Goal 3.4 that aims to reduce the premature mortality due to NCDs by 1/3 by 2030. And this framework for developing dialysis programs in low resource settings also highlights the need to adopt multi-sectoral policies that reduce the main risk factors which are common to all NCDs, as well as taking an integrated approach to developing the kidney replacement therapy programs that include both kidney transplantation and conservative management. And I would like to end again by saying that this pandemic has reminded us again of the very fragile health systems that exist in many countries, and the fact that we were making progress as a world towards achieving the SDG goals, both in non-communicable and communicable diseases, though it is slower in non-communicable diseases. But all of these programs have faced a setback now because of the pandemic, and we need to redouble our efforts, focus on building back, but building back differently, better, focusing on prevention, focusing on primary healthcare, focusing on using the digital tools and technologies, focusing on getting essential medicines to people who need them, and also focusing on this multi-sectoral approach, which actually looks at the more upstream risk factors that affect the development of non-communicable diseases, and in fact, really impact our health and well-being. And that is why WHO has as its goal and its strategy, the triple billion, what we call the triple billion goals, which really are looking at providing universal health coverage for another billion people by 2025, preventing and managing emergencies, as well as improving the quality of life and well-being. So it's not just about the management of diseases, but it's really about how to promote well-being. And I think that's, all of us can contribute to that goal. And I hope that we will get there as planned over the next 10 years that we have left to attain the SDGs. So I'd like to thank you again very much for giving me this opportunity, and really wish you very good deliberations in the conference. Thank you.
So thank you, Sumia. My name is Adira Levin, and I'm a past president of the ISN. And I think it's important that we, as a community, come together for this Global Policy Health Forum to help each other understand the current plight of people living with or at risk for kidney disease, as well as understand regionally and nationally, and apply those different components of our understanding to what we do in our day-to-day life. And I think it's been an interesting review, and our collaboration and deliberation with the World Health Organization as the International Society of Nephrology and as individual nephrologists in our own context is quite important. The rest of this session is really to set the stage for what we're going to hear in terms of the region. North American region at the International Society of Nephrology is particularly focused on Canada, North America, and Canada, the US, and the Caribbean. But everything that you're going to hear in the next small session, as well as the rest of this whole forum, is really can be applied to each of our own regions. So with that, I'd like to hand it back over to Vivek Jha to introduce this next Setting the Stage session. Over to you, Vivek.
Thank you, Adira. So we'll go straight into our panel. We have really an illustrious panel, and we'll start off by inviting Professor Sir George Allain to deliver his talk on Sustainable Development Goals in the context of chronic kidney disease and non-communicable diseases. Sir George is a native of Barbados and has had an illustrious career both as an academic and as a policy influencer. As a professor and chair of medicine at the University of West Indies, and subsequently as the director of the Pan American Health Organization. He has also been a UN Secretary General's Special Envoy for HIV/AIDS in the Caribbean, a Chancellor of the University of the West Indies, and on the Independent High-Level Commission on Non-Communicable Diseases of the UN. In 1990, he was made a Knight Bachelor by the Her Majesty Queen Elizabeth II for his services to medicine. And in 2001, he was awarded the Order of Caribbean Community, the highest honor that can be conferred to a Caribbean national. We are really pleased that Sir George will share his experience with us. Sir George.
My name is George Aline, and my presentation is the Sustainable Development Goals in the context of chronic kidney disease and NCDs. First, I have no conflict of interest. I will divide this presentation in three parts. I will speak about NCDs and chronic kidney disease as being critical for human development. Then I will pose the question as to whether SDGs are equal for NCDs and chronic kidney disease. And finally, I will discuss NCDs and ISN policy in the post-COVID world. First, NCDs and chronic kidney disease are joined together at the hip. In terms of etiology, chronic cardiovascular disease, hypertension, diabetes, air pollution, I put a star beside air pollution because it is not often recognized how important air pollution is for CKD and NCDs. We estimate that air pollution accounts for 3.7 million deaths annually from NCDs, and some 17 to 20% of the global burden of CKD is due to PM 2.5. We also share barriers to attention. There is no public hysteria over CKD and NCDs. And we are both partners in penury. If you examine the amount of money developed from the Development Assistance for Health, we find that less than 2% of the AH is assigned to NCDs. Also, there's a very small muted epistemic community for both sets of disorders. And of course, we have been neglected during COVID-19. We know that NCDs were omitted from the MDGs, I think in error, but we argued very strongly for the inclusion in the Sustainable Development Goals. And in a piece that some of us wrote a couple of years ago, we articulated very clearly, we thought that the reason for NCDs being embedded in the post-2015 development agenda. And the three messages from that were that A, that the post-2015 development agenda was a human development agenda, that health is a major contributor to human development, and that NCDs represent a major development, a major determinant of health. And one of my favorite slides shows this graphically. We show human development being supported by three major strands. There's a social strand, the economic strand, and the environmental strand, twisted together and linked together in helical form, and NCDs impacting on all three of those strands. Well, then came 2015, and the NCDs were included in the SDGs. And Goal 3 spoke to good health and well-being, and Target 3.4 specifically mentioned NCDs, speaking to reducing by 1/3 premature mortality from NCDs. When we picture the Sustainable Development Goals, they're often painted in circular form. One of them has the impression that all of the Sustainable Development Goals are of equal importance or of equal weight, and it's often been said that the SDGs are interdependent, integrated, interconnected, and all of the same weight. However, when one tries to look at the SDGs in terms of how they impact the NCDs, a very interesting presentation by Lux I hope I have the name correct, put the SDGs into 6 baskets, what they call 6 transformations. I'm not going to show you all of the transformations. They looked at the transformations and saw how those baskets of SDGs affected kidney health and well-being. So one basket was education, gender, and inequality. And they looked how all 3 of these together impacted negatively on kidney health and well-being. We have adopted a slightly different approach, and this is adapted from a presentation by a colleague of mine, Rachel Nugent, in which we look at the NCDs in relationship to those of the SDGs that have particular and peculiar relevance to NCDs. And when we look at it, we think that these 10 all have, these SDGs all have a relationship with NCDs, but that relationship is stronger in some than in others. And we pay special attention to SDG 10, SDG 10, which speaks to reducing inequality. And we think that this is one of the more important relationships of NCDs with the SDGs. And we try to display it in more graphical form in this way. NCDs, within the context of SDGs, NCDs inequality are related, and we point out that inequality is a major determinant of NCDs, and the arrow goes in both directions. However, we would wish to point out that an important feature of this relationship is that of inequality. And we think that there are some key stratifiers for that inequality. And what are these stratifiers? Stratifiers are characteristics of various subgroups that allows you to identify the differences which we think are unjust and can be labeled as manifestations of inequity. So we think in terms of the relationship between NCDs and the SDGs, there are major inequities, and poverty, education, and gender are the key stratifiers, the key things that divide people into groups that allow you to say that there is inequity in terms of our society dealing with NCDs. The idea that there might be a socioeconomic gradient for NCDs has been pointed out in this particular study from Johns Hopkins, which showed that there's a positive association between low income, low socioeconomic status, or low educational status and the NCDs. And we think that these differences in these groups, these differences are unjust and therefore represent inequity, and is one of the things on which we should focus at a policy level. As a manifestation of that inequality, if one looks at the percentage of patients with end-stage renal disease with access to kidney replacement therapy, it is clear. Those persons in the low-income countries have only 4%. 4% of those persons have access to kidney replacement therapy, whereas in the high-income countries, 60% of patients who need it have access to kidney replacement therapy. These data are taken from the Global Kidney Atlas, of which you'll hear a lot more later on. And what the Global Kidney Atlas also shows, that of the millions of patients who with end-stage kidney disease who need kidney replacement therapy, in 2010, of those who needed it, only 2.6 million received it. In 2030, of those who needed it, only 9.7 are projected to need it. And we project also that difference between those who need and those who receive, that difference will be magnified through those stratifiers that we mentioned earlier. Therefore, in other words, the poor will have a greater gap between those who need and those who receive. So we showed that NCDs are part of the Sustainable Development Goals. We point out the inequity in terms of dealing with NCDs and chronic kidney disease. a group of workers, the Lancet Countdown Group, has looked at the extent to which over the last 5 years there has been progress in dealing with the NCDs. And they point out that although most countries have made progress, it is highly unlikely that all of the countries will reach that target that was established in 2015. They're making progress, but unlikely to reach that target. And then came COVID. And after 5 years after beginning or into implementation of the 2020 agenda, we are struck with COVID. And COVID is having a devastating impact on all 17 goals. But we would like to point out that the impact of COVID is particularly noticeable in those persons with NCDs. If we look at COVID-19 and NCDs, the NCDs represent a vulnerable population. NCDs increase morbidity and mortality in COVID-19 disease, and unfortunately, there has been an impaired national response. Resources that were directed towards NCDs have been transferred to dealing with the COVID epidemic. And indeed, COVID has magnified the inequalities or the inequities in NCDs and chronic kidney disease. We would like to think, however, that in the post-COVID world, we will be cognizant of the differences that occurred before, and we will be cognizant of the need to sustain the best of what was done during COVID. So we would like to think that one can sustain the best of the COVID-19 response. And in other words, that surveillance systems that were developed will continue and be strengthened, but we will continue to make health systems more resilient in terms of being aware, agile, articulated, and adapted. That will continue to be civil society involvement, and there will continue to be emphasis on risk factor control. Now, the society at the last policy forum made several recommendations. All of the recommendations are important. I would like to focus on one recommendation, which is that of educating the public and people at risk about kidney disease and NCDs. I agree. But I would like to go further. And I would like to urge you to adopt a more aggressive approach, not only to educate, but to stimulate, animate, motivate, and agitate, and change what I call the docility of the NCD epistemic community, provoke a little more outrage at the inequity in the societies dealing with NCDs and chronic kidney disease. And what are the key messages? One, I would like you to put out the message that especially in the post-COVID world, there's a close linkage between NCDs, chronic kidney disease, and the other SDGs, but please stress the inequality, the inequity in dealing with NCDs and CKD. Please do not shrink from the instrumental approach. We often speak of NCDs in terms of mortality, but please emphasize that NCDs reduce the stock and quality of human capital and impair productivity. And please engage in the post-COVID agenda, emphasizing the inequality that has been accentuated by COVID. And who are the messengers I would like to see you engage? I'd like to see more political entrepreneurs, more champions for NCDs and CKD. The Rita Thunbergs, where are they for NCDs and CKD? I would like to have you make the epistemic community much more active in putting out the message that the society as a whole has to deal more aggressively with NCDs and CKDs, that they're important within the Sustainable Development Goals, but the aspect of inequality, inequity, is one that has to be stressed. I would like you to also involve more actively those persons living with NCDs. As I've said before, many of the discussions and presentations start with mortality, people who die. But in addition to the people who have died, regrettably, there are billions of people who are living with NCDs. I reckon that 1/3 of the world's population lives with one or other of the NCDs, including chronic kidney disease. And please do not forget the youth. Please do not forget that the youth that some of the conditions that occur in the youth are predisposed to chronic kidney disease and NCDs. And of course, civil society. And I'm pleased to see the association being an active member of the NCD Alliance. Thank you very much, and good luck.
Thank you, George, for your very stimulating address and invocation of the need for the younger generation to rise up and take this challenge up. We'll come back to some of these points during the question and answer session. It's my pleasure now to welcome Dr. Aminu Bello, who is a consultant nephrologist at the Division of Nephrology and Immunology at the University of Alberta. He is a global citizen, having trained in Nigeria, UK, and Canada, and is now a member of the Alberta Kidney Disease Network. He leads the Global Kidney Health Atlas along with Dr. David Johnson of Australia for the International Society of Nephrology. And he has established actually a team of scientists, healthcare policymakers, clinical leaders, educators, and knowledge translation experts at his division. Dr. Aminu will present findings from the Global Kidney Health Atlas for North American region and provide context and comparisons. Dr. Aminu, please.
Hello, everyone. I'm presenting to you the ISN Global Kidney Health Atlas with a focus on North America and Caribbean region. The Global Kidney Health Atlas is an initiative by the ISN under its research portfolio conducted to understand, compare, and monitor how different countries around the world detect, treat, monitor, and advocate for people with kidney disease, including acute kidney injury and chronic kidney disease. The key focus was on availability, accessibility, affordability, and quality of kidney care. We leverage the standardized element on health system building blocks by the WHO to collect data for Global Atlas, focusing on various elements from workforce, availability of medication, funding for healthcare, health information system, and so on. The results were presented and summarized by the various ISN regions, which are 10 in number. For this particular region, we had 10 countries that participated in the survey in 2019, representing over 99% of the region population. The key result from the first iteration of the Atlas was summarized on this slide, where we had 125 countries participating, representing over 90% of our global population. The findings were published by the JAMA in 2017, showing the significant limitation with services for kidney care across all countries and regions. The survey was repeated in 2019 with a particular focus on end-stage kidney disease, now called kidney failure, where we had 160 countries participating, representing over 98% of the global population, showing significant deficiencies and limitation regarding the various elements required for optimal kidney care of patients living with kidney disease. This report and the original findings were published by BMJ in 2019. In the next slide, I'll be focusing on availability of services for dialysis and kidney transplantation. I will first show you the summary of the result globally, where most countries in the world will report availability of dialysis centers, about 4.5 per million population. For peritoneal dialysis, about 76 countries had availability of service, with about 1.3 centers per million population. For kidney transplantation, also 74% of participating countries reported availability of service, with 0.4 million, 0.4 centers per million population. For these regions, there's also significant variability, remembering that this is a region with variable population density, as well as healthcare expenditure across every country seem to be quite different. The region has done well compared to other world regions, as all countries will report some availability of hemodialysis centers. The average for the region was above global average, with 18 centers per million population. That also showed a significant variability across countries within the region, with some of them having 30 centers per million population and others having 4 per million population, as in Jamaica, for example. Similarly, PD services was available in 7 countries with 7 centers per million population, which was far above global average of 1.4 per million population. Similarly, for kidney transplant, we had about 5 countries reporting service with about 0.7 centers per million population, above global average of 0.4 per million population. Regarding funding for non-dialysis CKD, only 20% of countries provided a universal coverage for care of patients with kidney disease that is free at the point of delivery, which is also a similar pattern for funding for patients with living with kidney failure, meaning dialysis or transplantation. Regarding availability of the nephrologists, the current global average was about 10 per million population, with highest in Japan, lowest in Mozambique with 0.1 per million population. This also shows significant variation within the region. For example, the United States had twice the number of nephrologists per million population than Canada, and Antigua and Barbuda had the highest nephrologist density with about 30 per million population, for example. There was reported shortages of various cadres of healthcare professionals, including surgeons, dietitians, and psychologists and counselors across the various countries highlighted in red. There was also significant limitation regarding the availability of surveillance system for acute kidney injury and CKD. There is no established registry at a national level for AKI or CKD in any of the countries of the region at the time of the survey. So the summary of the data I have shown over the last couple of minutes will show that North America and Caribbean region has done relatively well compared to other world region in terms of availability of and access to kidney care services. There are, however, significant gaps and limitations. In particular, kidney transplantation services are quite limited in many jurisdictions in the region. There was limited public funding for universal kidney care. There was non-availability of the registry for AKI and CKD. There was limitation also in some element of workforce, in particular vascular surgeons, transplant surgeons, and nurses. This has significant implication in the way kidney care is organized and structured in the region. There was also a need for using this information to develop policies for optimal kidney care in the region by increasing funding towards prevention and management of patients with kidney disease. There was also a need to address the various highlighted workforce shortages, in particular transplant surgeon, vascular surgeon, and nurses. There was a need to expand the health information system for monitoring with kidney disease, in particular for acute kidney injury and non-dilated chronic kidney disease. This can be done by using some of this data to engage with relevant stakeholders and government organizations at country level, as well as other international stakeholder organizations at the regional and global level to promote and advocate for development of sustainable and equitable kidney care policies across the region. We have provided a number of materials to support this. A number of summary slides were available on ISN website, including user manual on how to use them. We encourage you to share these materials with colleagues and key stakeholders to support kidney health practice and policy in your individual country and region. We provided the copies of the Atlas free online from 2017-2019, as well as a number of publications arising from the exercise, including the original paper published by JAMA in 2017, and various other articles covering various facets of the healthcare system organization specific to kidney care, including workforce, registries, essential technologies for optimal kidney care, published by Kidney International. The BMJ published the second iteration of the survey, which highlighted significant gaps in care for patients living on dialysis or kidney transplantation. The ISN as an organization is working closely with other stakeholder global bodies like WHO and other UN organs to use this information to provide optimal kidney care, in particular for people with kidney disease living in low-income nation. Thank you for listening, and I'm ready to take questions.
Thanks, Aminu. It is my pleasure now to invite Professor Adira Levin, past president of the ISN and the head division of nephrology at the University of British Columbia in Vancouver, Canada. She is the senior medical lead of integration, clinical and academic networks at the Prevalence Healthcare and the executive director of the BC Renal Agency, which oversees the care, planning, and budget for kidney services in the province of British Columbia. Professor Levin has been active across the spectrum of kidney activities and has, of course, had leadership roles at the ISN. She was one of the founding members of the Declaration of Istanbul Custodian Group and served as one of the first co-chairs of that group. She is a passionate advocate for patient rights for equitable access to care and in the prevention of exploitation of vulnerable populations. Adira will contextualize the 12 recommendations and provide a high-level overview for the North America region.
Good morning, good afternoon, or good evening, depending on where you are. And thank you very much for coming to this Global Kidney Policy Forum. And I'm going to try and give you a little bit of context and the 12 recommendations, as well as a high-level overview of the North American region. To give you some context, in July of 2016, a group of clinicians, researchers, translational scientists, industry, and other groups of people met to identify and address the gaps in care, research, and policy for global kidney health. And this was published in The Lancet in 2017. And in that work, we actually identified a number of key things that needed to be done. Improving the identification of kidney disease and reducing risk factors through strengthening surveillance and tackling major risk factors, improving and understanding the causes and consequences of kidney disease, and developing and testing new strategies. Those first two things are important in terms of this public policy forum, because through this we can heighten awareness and develop actions very much to strengthen surveillance and tackle major risk factors. This ISN Global Kidney Policy Forum started in 2017 in Mexico City. A second one was held in 2019 in the Oceania region in Melbourne, Australia. And this in 2021 is to address the North American region. Importantly, each region has its own particular issues and diverse perspectives, but in addition, it has things in common. And so each one of these is truly a global kidney policy forum. The desired outcomes of this kind of a meeting are ultimately to improve the outcomes of people living with kidney disease. But if we can all increase our awareness of how big this problem is, if we all can address changes that are required to impact the problem from our own region, country, locally, or nationally, that will be important. And if collectively we can commit to change, then we will reach the desired outcomes of this policy forum. There are 12 recommendations that we put together in 2016-17. And what we really want is people to sign, either virtually or actually this document, as a testimony and a call to action. And they're listed here. I won't read them all to you, but it's really to work within any current framework. You've just heard talks from WHO and PAHO, trying to look at the Sustainable Development Goals, universal coverage, and a life course approach to health. Look at implementing public health policies, have ongoing surveillance mechanisms, educate public and people at risk, improve awareness, work towards the sustainable access to effective and affordable medication, support education for skilled workforces, think about the things we need to know about acute kidney injury, integrate early evidence-based treatments with other non-communicable diseases, and look at developing and implementing policies that allow equitable access to all care, including dialysis and transplantation, expanding kidney transplant programs, and supporting research on kidney disease. Through all of these different actions, and we will actually come to some different place. And so to tell you a little bit about this region, there is diverse geography, diverse populations within and between, very different healthcare systems, both within and between each of the different countries within this region. And all of those give us challenge and success and opportunities for success. I've written here in alphabetical order, Canada, the Caribbean, and the US. This is what constitutes the International Society of Nephrology North American region. And you can see by what I've written that the geography of Canada is larger than that of the US, and yet we have 32 million versus 328 million people. In the Caribbean, there are multiple territories, islands, and sovereign states with a small land mass ultimately of less than 3 million square kilometers and only 7 million people. And so in essence, what we're talking about is a diverse region with diverse challenges. And I think that that's part of the point of this policy forum, to really help us understand that and use it in a way to change things. This meeting has been structured with an opening session. This is the last talk in that. And we've tried to set the scene. You've heard WHO perspectives about the Sustainable Development Goals. And lastly, from my colleague in Canada, the Global Kidney Health Atlas, and what that tells us about the state of kidney care in the world. This next section, the meat, if you will, of this meeting is about quality, sustainability, and the equity of access to kidney services and care in these three countries, this region, and with a little bit of an emphasis on COVID-19 and kidney care and how that has increased the challenges and perhaps the opportunities. And at the end of all of this, we will have summary and a commitment to the next steps. And so with that, I want you to reflect upon these desired outcomes, understand them, and think about how you in your own region, in your own country, might well be able to actualize or act upon these 12 recommendations. So with that, I want to remind us that we have diverse perspective during this global policy forum. We have the opportunity for discussions either via chat or afterwards amongst yourselves in your own countries, regions, and hopefully together one day. And there are many people at this meeting representing those perspectives, patients and patient groups, health administrators, ministers of health, various important international and national organizations, as well as kidney doctors, researchers, and public health experts. And so with that, I want to close this session, open it up for question and answers, and remember that we're here to have a global kidney policy forum while focusing on North America under the umbrella of the International Society of Nephrology, where we truly believe in advancing kidney health worldwide together. Thank you very much.
Thanks a lot, Adira, and thanks a lot, Aminu and George. We now have some time for questions. So let's get going. We have heard a diverse array of presentations with range of perspectives. And if I might start with you, George, you presented a very interesting approach and suggested that we go beyond educating the public to maybe becoming more active and even agitate Are you suggesting that at least the younger amongst us should also take the path to activism, to agitate? How do you think that might happen? And what kind of change in approach will be needed to bring that into action?
Thank you very much, Vivek. First, I agree with you, and I would advocate vigorously that the younger ones in the society be more active. The second point I'd make is I would think that education, I notice in discussion about stakeholders, you mentioned governments, but it's the people who are living with the chronic kidney disease and NCDs that must be more actively involved. The third point I'd make is in much of the advocacy, we seem to accept as normal that there be inequality. We seem to accept as normal that there be some people who have and some people who have not. And I'd like to see that wiped out from our lexicon. We may not get there, but there should be a much more aggressive approach at seeking equality. We mightn't get there, but don't let us start with the idea that this, when we present our data, that there is inequality. We should be looking at what are the mechanisms for increasing this or decreasing this inequality. And I would posit, as I said in my slide, one, involve more young people in being more active. They're much more entrepreneurial in this area than we old folks. To involve more aggressively the people who are living with chronic kidney disease. Involve more aggressively those persons who have had kidney disease but are now recovered. I don't see any mention in the discussion about those kinds of persons. So it's in fact widening the network of persons who are going to be aggressively advocating for this reduction in inequality that I would put as the pivot of this enhanced education. Thanks, Vivek.
Thanks, George. Aminu, if I might go to you, of course, the Global Kidney Health Atlas is such an invaluable tool that has helped define the current status of kidney health, both acute kidney injury and CKD care worldwide. As we saw during the comments coming in from the chat, whenever people hear about the Global Kidney Health Atlas findings, they are completely amazed at the kind of response that it got, more than 98% response rate. So it's amazing. I don't think there is a parallel example of any other similar kind of survey done by any society around the world. So what do you think is the next step for the Global Kidney Health Atlas? What is the group already thinking of doing new that would improve upon the information that we already have? And how can we do whatever we need to increase its coverage?
Thank you very much, Vivek and Adira. Thank you very much for the opportunity to be here on behalf of myself and David Johnson, my co-chair, to present today. So as you all know, you are our leaders. The Global Kidney Health Atlas first iteration was launched in 2017. And in that first iteration, we documented for the first time the current organization, structures, and delivery system design for kidney care across all countries and regions. That first iteration focused on the full spectrum of kidney care, from acute kidney injury to chronic kidney disease and kidney failure. We monitored all the gaps, all the issues, the problem. And in 2019, it was repeated with a special focus on the kidney replacement therapy, dialysis, transplantation, and capacity for conservative kidney management. So the goal is for the ISN to use this information to engage with stakeholders at various countries and regions to help advocate for optimal kidney care around all countries and region. And the exercise will be repeated in a 4-year cycle to monitor progress, how the countries are doing in closing the identified gaps in kidney care. The original plan was to launch it again in 2021, but obviously because of the pandemic across the globe, it became a huge challenge. So we are planning to conduct the next exercise in the coming year in 2022 and launch it in the WCN of 2023. So as I said, the goal is not just to document information, but it's for the nephrology leaders at country level, regional, internationally, to work with various stakeholders to make the kidney care better around countries in the world, particularly the low-income nations.
Thank you, Aminu. Adira, you have been critical to setting off the Global Kidney Policy Forum, its very first edition at Mexico City, and subsequently. Could you tell us about the policy changes that the previous editions of the Global Kidney Policy Forum have led to, and the new relationships and collaborations that it helped ISN to enter into?
Yeah, no, thank you, Vivek, and thank you to all of you for listening and taking this on board. So, the success in Mexico City with various policymakers present in real time and in 3 dimensions at that meeting was quite profound. They had never had a dialysis registry in Mexico, but after that forum and the stress of the importance of having documentation as outlined by Sir George and Sumia, as part of the goals, they actually were able to achieve that. And that was a fundamental awakening, if you will, of the Mexican group in terms of what was needed. In addition to that, we have solidified our relationship with the WHO, with the Global Coalition of Circulatory Health, and have had places at the table and get the word kidney mentioned at things. And to Sir George's point and others, we need to agitate a little bit more. I think if each person takes away one of those recommendations and figures out how they themselves can actually articulate and advocate for and agitate, the 3 A's maybe, for one thing that is very near and dear to their heart, I think that would get us somewhere quite different. And I think, as Aminu pointed out, by knowing what's going on in your own region and then being able to go to policymakers with data about what you do and don't have, whether that's in Canada, within your province, in the US, within the States, or within the Caribbean, I think that actually helps because people don't know what they don't know. And so with data, you can help to both argue and educate those policymakers and see them how to connect the dots and then get somewhere different. So it's baby steps, but I think we are getting somewhere different. And I think it's with that accrual of information, data, and passion that we can change things.
Thank you, Adira. We are coming close to the end of our time, but if I can ask you, George, very quickly, if you can provide some insights on how do we ensure that preparedness and prevention remain appealing to policymakers in non-pandemic times as well?
I didn't get that. Please. I didn't get that, Vivek. How did he?
So everyone is talking about preparedness and prevention now, but how do we make sure that this message sticks?
Oh, thank you very much. Repetition, 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 and repetition in all fora. Repetition by those who are not affected as well as for those who are affected. The more you repeat it in fora of which they're not only nephrologists, the better it will be.
Thank you. That's very important, and I think very succinctly put. We have come to the end of this session, but there have been a number of questions which we have all taken note of, and they will all be responded to either individually to those who asked, or they will be up there on social media. Please also note that there is a networking session which is open for the duration of the Congress, so please go to that networking session and interact with colleagues. All that remains for me is to once again thank all our speakers here and thank the audience also for joining in and being vigorous in asking your questions. I request you to, even as we end the session, please go back and take a moment to click on the next session to go to the next room. This is because of the very peculiar virtual nature of the meeting. Thank you all for your participation.
Jishwit, my name is Dr. Evan Adams. I am from Tla'amin Nation, which is one of the Indigenous tribes on the west coast of Canada. I am a physician, and I'm here to talk to you today about Indigenous health and wellness, challenges and opportunities, and a focus on kidney diseases amongst Indigenous people in Canada. I'm the Deputy Chief Medical Officer at Indigenous Services Canada, which is a department of the federal government. So here is a map looking at Indigenous populations in the United States and Canada. Of course, there are Indigenous peoples all over the world, about 400 million of us in about 80 different countries, including the Americas, but on almost every continent. And this shows us a color gradation of percentages of Indigenous peoples in provinces and states in the country. And you can see, particularly in the northern regions of Canada, that there are very high percentages of Indigenous people. And here's just a photo of an Indigenous man or a First Nations man powwow dancing. And again, a representation of, and it's very important to show a very different viewpoint of the Americas from an Indigenous point of view. Canada and the United States have Indigenous roots, and it's important for us to acknowledge those. And the countries of Canada and the United States are superimposed on hundreds of nations that have been existing there for many thousands of years, and they continue to exist. And we see this coexistence almost like nations within nations. Here's a description of the Aboriginal population in Canada. We comprise almost 4% of the population, which is not insignificant, but certainly not a majority. And the three Indigenous groups or Aboriginal groups in Canada are the First Nations, or the Red Indians, or the American Indians. Of course, Columbus thought he was in India. He wasn't. He was in the Americas. The Métis, who are a distinct culture of mixed race people of French and First Nations descent, and the Inuit or Eskimo way in the north. And here's a photograph of a depiction of my area of where I'm speaking to you from. Tla'amin territory. We're part of the Salish-speaking tribes. This is the northwest corner of Washington State in the United States. At the bottom of the picture, the southwest corner of Canada in the province of British Columbia, and that island there is called Vancouver Island. And the city of Vancouver is in there somewhere, just so you can situate yourself and me. And my people have been there for a very long time. And here's a photograph of part of our territory. It's very beautiful, and Canada is a large country. A lot of its lands and waters are quite pristine. We're very lucky. So First Nations in Canada have a long history of health and wellness, and like many Indigenous peoples or original peoples, waves of migration have pushed them to the margins of their territories, sometimes literally the margins. They live on the edges of society. And so even though Indigenous peoples around the world don't necessarily have genetic similarities, they often have social similarities, meaning that their health is in decline and they've been challenged by colonization, things like in Canada, residential schools, Indian hospitals, something called the 60s scoop, where Indigenous children were removed from their families for questionable reasons, and an extremely high incarceration rate. All of those are terrible for Indigenous people's health. So this colonial inheritance does color the current situation around chronic diseases, including kidney disease. I thought it was important for us to look at the organization of the health system in Canada, and I just really want to show you here the federal government, which, as far as federal governments go, is small, and here are the responsibilities for health transferred over to the provinces with transfer payments. And this gives the federal government largely a fiduciary responsibility, the provincial government responsibility for the services. And these services are quite large compared to the size of the federal government. So the provinces are major players. And that's really all I wanted to show you here. And for those of you who work with Canadians or with Canada, you might recognize some of these other entities. So I thought I would just put it up there for you to see just for a moment. It's very important, though, in Canada to state the federal, provincial, territorial ministers of health in January of 2016 named Indigenous health as one of the most important priorities in the country. This is a very important framing for Indigenous health, in that there are quite large-scale efforts, and I think political will and public health and social investment are indicators, social indicators of health. So this commitment, I think, is changing the picture of Indigenous health today. Well, we don't have a lot of statistics about renal disease for Aboriginal or Indigenous peoples in Canada. Here is an article from the Canadian Medical Association Journal by Collier around the higher prevalence of renal disease for Indigenous peoples. And we do know that Indigenous peoples come in last in almost every socioeconomic indicator and in almost every health indicator in the country. Some provinces are worse than others, but even in our own lands, we come in last. And I will, hopefully some of the discussion that we've had, or some of the points I've made earlier about colonization, show you why we have this kind of inheritance. In British Columbia, the province where I'm from, and that is arguably one of the most advanced at looking at the health of First Nations, showed that there was a much higher rate of chronic kidney disease, lower rates of transplantation, and a number of kidney-related issues. And the data also tells us that compared to non-First Nations people in BC, we are overrepresented in the emergency departments, which is a proxy telling us that everyday care is lacking and people are going to emergency departments or acute care to receive the care that they need, that we have fewer visits with general practitioners, surgeons, and specialists, meaning that we are underrepresented in the healthcare system. There is a myth that we are overrepresented in the healthcare system, and that's not true. And one of the reasons we supposition we don't see ourselves there is because of a lack of relationship between Indigenous peoples and healthcare providers. Just going to keep going. So here's what we know. In the lack of data, specific data around kidney disease, the report of the Royal Commission on Aboriginal Peoples from the 90s, and this has been known for a very long time in Canada, is in almost every socioeconomic indicator, including educational levels, employment opportunities, housing, per capita incomes, etc., which have direct effects on health outcomes, meaning that our health is poor and our kidney health is poor, is very well documented. And some of the barriers, besides looking at just general issues of health action or service, is that, let's not be naive, racism exists within the healthcare system. There is stigmatization of Indigenous peoples in Canada and the United States. There is a lack of traditional healing and wellness approaches. Indigenous people have their own health and wellness knowledges, health and wellness systems, and those are excluded from the current Western system, and that can marginalize Indigenous peoples. And that some of the siloed approach within the healthcare system, the Western healthcare system now, is very problematic. So in British Columbia, we, instead of looking at simple health actions, we also looked at the idea of governance. Who is in charge of our health? And self-determination on a personal level is the right of the individual to determine their own course, but on a political level, the right of a nation to determine its own course without interruption from another nation. And so we would ask the question, who is in charge, for instance, of Indigenous cancers? And so by asking that question, then we can pull the correct levers in order to ask for change. So just to put this very simply, And this image is just to remind me of being at a negotiating table and asking the question, who's in charge in this situation? A child had died, an infant had passed away, and the chief of the community had asked for a better service from the coroner. He wanted the baby's body returned more quickly than it had been in the past. And the chief coroner of the province said, well, here are my authorities by law, literally by a law called the BC Coroners Act. I'm allowed to keep this infant body for as long as I see fit in order to determine the cause of death. And the chief slammed his fist on the table and said, we know you think you're in charge, but we think that's our baby. And in the hundreds of meetings that I had been at in trying to get Indigenous influence over Indigenous bodies, hearts, and minds, that was the clearest illustration to me of why Indigenous people need to be at the table to talk about their own health and well-being. One of the ways that we hear about, one of the ways that we think about data are stories as data. And recently, we did several surveys around Indigenous people health and their experience of the healthcare system. And there were literally thousands of stories and responses within a very short period of time, just a period of months, saying that they were encountering racism within healthcare. This was a revelation in some ways, but also mundane in another way, because we knew that these were happening because we heard it so often from patients, but also we were hearing it from healthcare workers. They were becoming more at ease in describing their experiences within the healthcare system. And what we've learned, and what I've learned, and what we would like for other people to know, is that we need to bring more than our Western training, more than our medical training, in order to make a difference in the most marginalized of peoples. In our culture, we are supposed to bring an authenticity, humility, and respect to our encounters. We're meant to be the best that we can be in order to help people to be well. So we talk about this idea of cultural humility, which is a perspective of the caregiver to be humble and to know one's place, that we're working from a particular point of view. For instance, as a clinician, let's say you're in a patient's room, you're bustling around trying to write your note or take vital signs, do a physical exam. But for the patient, that may not be what they're thinking about. Let's say they're an older Indigenous woman who doesn't speak English. They're with an adult daughter, and the mother is not feeling well at all. And the family is asking, can you please be quiet and let her rest? And cultural humility is the acknowledgement that you have your own perspective wanting to get your job done, but then there's this other perspective external to you, and that they can coincide. And the key to that is respect. There doesn't need to be what we would call a disrespectful humiliation, diminishment, demeaning, or disempowerment of an individual because of their cultural origin. And I just wanted to point out that we have taken, or this has been in discussion in Canada for long enough, that the Royal College of Physicians and Surgeons in the country, which has over 50,000 physician members, has made commitments towards cultural safety and humility in the training of their residents, but also in continuing medical education. In order to arrive at flying in a different way, sometimes we have to leave behind the old way of looking at things. And we hope that we can make changes in the system to include more and more Indigenous perspectives and voices. Thank you very much.
Thank you very much to the organizers for giving me this opportunity to speak to you about challenges in delivering kidney care to rural, remote, and Indigenous populations in Canada. So in Canada, we face challenges that are very similar to Indigenous populations elsewhere. And these include high prevalence of CKD, mostly secondary to diabetes, obesity, and hypertension. And there's a high and increasing need for renal replacement therapy. And our goals are to provide comprehensive, best possible care to our Indigenous communities, including screening for diabetes, hypertension, and chronic kidney disease, providing a multidisciplinary approach to renal protection, providing dialysis as close to home as possible, and providing access to timely transplantation. Oops. This is a map of Canada, just to show you that Canada is a vast country of 35 million people. The population is concentrated mostly in cities in the southern part of the country. Our Indigenous populations, there are many communities that are in the south, close to urban centers. But one of the challenges we face is that many Indigenous communities are in the northern extremes of our provinces and in our territories. And the distance from areas of specialized care is a real challenge. Canada is a federation of 10 provinces and 3 territories. Each province is responsible for delivery of healthcare to its population. And I will focus mostly on Quebec, where I practice in the city of Montreal, and tell you a little bit about our experience with delivering care to Indigenous populations in Quebec. So this is a picture of the province of Quebec. It's the largest province geographically, the second largest province by population. The largest urban centers are in the south. Montreal is over here. Quebec City is here. And there are several medium and smaller urban centers scattered around these 2 large population centers. In terms of Indigenous populations, you can see from the color circles, which indicate Indigenous communities, that there are some in very close proximity to population centers, and people who live in these communities have easy access to medical care, pretty much equivalent to other Canadians. In contrast, there's a large area of northern Quebec, which we call Nunavik. It's larger than the state of California. And this area is populated by about 10,000 Inuits who live in 14 communities along the coast of Hudson's Bay and Ungavda Bay. There are 2 airports that are open year-round for accessing these areas, but there are no roads. There's no road access. And the smaller communities depend on either fly-in, fly-out planes, depending on weather. And in the summer, there's seasonal ship access, but the summer season is very short. So this area is very remote, and the distance is certainly a challenge. You can see that from Montreal up to the further part of Nunavik is about 2,000 kilometers. A more intermediate area is the James Bay area of Quebec, which is the Cree territory called Iuichi. In this area, there are 18,000 Cree people who live in 9 communities. Some are on the coast of James Bay and some are inland. And this area is still very far from Montreal. It's about 1,400 or more kilometers from Montreal. But in contrast to this northern area, there is a network of roads that connects the communities to Montreal. There are 2 regional airports, and there are airstrips in most of the communities that allow air access year-round to Montreal. And these communities have access to 2 or more regional hospitals that provide primary and secondary care. Because of the easier access, we have been able to establish 3 satellite dialysis units, one in Chisasibi, one in the village of Mistissini, and another one in the town of Chibougamau, which provide dialysis close to home for many of these patients. This next slide just contrasts some of the difficulties and differences in providing care to these 2 areas. So in the far north, in Nunavik, as I mentioned, we have 10,000 people living in very remote communities with no road access. There are medical clinics in each community with a nurse present. Many have doctors, but not all. And nephrology care is provided only by consultation request. There is some screening for diabetes and CKD, but it's not a highly organized program. CKD prevention really depends on our general internal medicine colleagues who do some visits in telehealth. When patients develop end-stage renal failure, they have no choice but to move to Montreal. This causes displacement from their community and culture, really for the rest of their life. We get very few referrals for dialysis from this community, less than 10 per year, and many patients decline because of the wish to stay home and not be displaced to Montreal. All specialized care depends on visits to Montreal. The Cree community in Iuichi is, as I said, intermediate in the James Bay region of Quebec. They have access to local hospitals and easier access to major specialized centers. The Cree are a wealthy community with a highly organized and developed Cree national government and a very highly developed Cree Health Board, which delivers medical and social services to the community through a network of health clinics with a physician, nurse, and paramedical staff present and one community hospital. Nephrology, myself and my colleagues at the MUHC provide nephrology care through regular visits to the communities as well as telehealth. Screening for diabetes and CKD is extensive and formal. There is a CKD prevention program. In terms of renal replacement therapy, there is very high buy-in from this community because of the 3 satellite units that we have in 3 of the communities. So we have 62 patients who are dialyzed close to home or in their home communities. Another 18 or 20 patients who are at the MUHC, either because there is no dialysis available in their community or they may be waiting for a place to transfer. And we also have several patients in the region on home dialysis, both home hemodialysis as well as peritoneal dialysis. Patients still have to come to Montreal for specialized care, and they have, for transplant evaluations, we do as much as we can locally, but they still have to come to Montreal for some of the specialized tests. So what are some of the challenges? Well, I mentioned, and it's pretty obvious, that one challenge is distance. Another challenge is limited diagnostic ability to diagnose the type of renal disease. Most of the patients have diabetic nephropathy, and if patients have proteinuria with a bland urine sediment in the context of diabetes, we usually assume that they have diabetic nephropathy and only bring them to Montreal for further investigation if there are clinical features that suggest disease other than diabetes. There's a strong emphasis on medical treatment, whether RAS blockade or SGLT2 inhibitors, and there isn't enough attention paid to other equally important factors such as patient education, dietary counseling, weight loss, smoking cessation, etc. Sometimes we run into issues of jurisdictional governance where it's not clear as to who is responsible for program development or dialysis administration. Is it the nephrology consultants who take responsibility for implementation, or is it the local community? And it's usually more of a shared model. Patients are required to come to Montreal to initiate dialysis. For some patients, this is a permanent displacement, and for others, it's a long wait for a place near home. This is really very challenging and causes a lot of distress for patients who have to stay in Montreal for a long time. It's very disruptive to their lives and to the lives of their families. We promote home dialysis, but there are significant barriers to home dialysis. One is patient-centered, namely obesity in much of the population. But there are issues with delivery and storage of supplies, sometimes community resistance because of anxiety about having a complex patient in the community. And there can be issues with easy access to urgent care. Personnel recruitment and retention is difficult. The farther the community, the harder it is to recruit and retain staff. And another issue relating to personnel is that there's a lot of staff rotation of MDs and nurses, and this makes it challenging to provide good continuity of care. When patients come to Montreal for a long stay, there's a lack of support. We focus on providing good medical care, and we provide good dialysis when patients are in Montreal, but we do not provide them with sufficient psychosocial support. We don't provide them with good dietary options and access to their native diets. And we don't provide them with well-organized recreational, social, educational, and occupational activities to occupy their time. Sometimes we have to deal with mistrust and ambivalence by our patients toward conventional medicine and treatments, and we have to be open to the use of more traditional medicines, usually together with the therapy that we like to provide. There are some cultural barriers to regular attendance to appointments and sometimes to dialysis. The Cree patients in particular like to maintain their traditional bush life and spend as much time as possible in the bush. Sometimes they work far from home, and there are often, especially in younger patients, serious substance abuse problems that can make regular attendance to medical appointments and even dialysis an issue. And finally, we have to be aware and sensitive to systemic racism and discrimination in our own culture, and always be vigilant to treat our Indigenous patients with proper respect and sensitivity. Thank you very much for your attention.
Thanks so much to Evan and to Murray for great lectures, really addressing the challenges that we have in approaching Indigenous patients throughout Canada, and it's applicable globally. And what I'd like to do now is sort of open to the audience for questions. It's important for people to note that questions can be put into the chat, and that we're able to actually read through the questions. And there are a number of them here. And I think some of them are just mostly comments, so I'm not sure if the speakers can see this, but a lot of greetings from people, and that the lessons that come from a disadvantaged communities in Canada are also relevant everywhere. And I think the comment about cultural humility and respect that both of you spoke about is incredibly critical. If there's no specific question, I think a lot of people are interested in this idea of cultural humility. And so I'll probably pose the question first to Dr. Adams. Dr. Adams, one of the things that I like so much about that term is that it's actually applicable in the social sense to almost every patient that we see. We should think about cultural humility. And what I wanted to understand was, what is the practice that you think we need to put in place within Canada for Indigenous people that's really appropriate for everybody? How should we think about both teaching cultural humility as we think about medical school, but also how should we put it into our practice?
Great. Well, I think one of the first ways that we can address cultural safety and humility is with education. I am surprised how little Canadians learn about Indigenous peoples and about the lands where they live. So for instance, we know how to say hello in many languages, but most people don't know how to say hello in the local language. Indigenous people, for whatever reason, for whatever historical inheritance, are seen as very distant cousins who are poor and live down the road and are a bit of trouble. So one of the ways then to rectify that is to actually learn about Indigenous peoples and what happens to original peoples when they meet with settlers. And this happens everywhere in the world. It's not a big deal. We have legs, we're not barnacles. So people move in and out of territories all the time. And learning about local cultures is, I think, the only way that we can succeed as a multicultural, pluralistic society, and not saying, and not embracing the model of a dominant culture and all of the others acquiescing to the dominant way of thinking and being. I think last of all, especially for physicians and physician training, some of our training places us at the center instead of placing us in a supportive role. And that's why I very purposely said, and I didn't want people to be scared of that, I purposely said to know your place, as in you are only part of quite a large group of activities around a patient. And we need to recognize the importance of, well, other professions and disciplines, but also of the family, particularly of Indigenous communities and Indigenous well-being. Thanks.
Thanks so much. I think that comment about we're not barnacles and we've got legs, and that we really need to move and find out about our community is incredibly critical. And thank you so much for that. Dr. Vasilevsky, we wanted to ask also, somebody put in the chat that, can you sort of comment that, in 2011, they had a patient who decided to go home and die in Nunavut rather than get delivery of care of dialysis and have to move to the city. And have we really not made progress since then? And what are the barriers that we need to really challenge ourselves with in the next year? Like, what's imminent that we need to handle?
Yeah, unfortunately, that patient story that someone referred to is something that really happens. And I've had the experience myself of a woman in her 30s who had end-stage renal failure, came to Montreal, was not a candidate for home peritoneal dialysis because her community was so remote. There was no way to deliver supplies, no way to properly store supplies, and no way to move her out of the community in the event that she might fall ill with peritonitis or something worse. So it was out of the question for her to do dialysis in her home community, and she had to come down to Montreal. After a few months, she missed her family and especially her children so badly that she just decided to give up on dialysis and return home. And she was able to survive for several months with her residual renal function, but eventually succumbed to her disease and passed away. And this type of scenario is absolutely tragic in 2021. And it's very, very challenging to find a way to get around that, because the Inuit communities in northern Quebec and many other parts of Canada are just so remote that it's hard to establish a dialysis program that's close to home. So I think, we may, with new technology, be able to develop easier systems of dialysis delivery that would make it realistic, but we're unfortunately quite a long way from that.
Thank you. So I think it is challenging for us, I think, even with telemedicine, because the idea for dialysis care, the question is, what can we do closer to home to be able to make sure that people can live close to home and really have the best quality of life, and then make those choices, and I think that's hard when you only have a choice of life-saving therapy hundreds or thousands of miles away from your home. And I think that's a really complicated question, and we put families out, and we really need to think creatively about how to handle that. So I'm being told that I need to make sure that you all move to the next session. This was a great session. Thank you very much to both of the speakers. There are a lot more questions or comments I'd really put in the chat. I think people are really interested in understanding what we can do within Canada to do better. And I think we have people from Africa who are also sending in chat saying they thought it was only in Africa that you had to deal with these things. And how do we do that in a first world, in a high resource country? We should do better, right? And I think COVID has challenged all of us worldwide and really showed where our holes are in our care, and we clearly need to do better. And so thanks so much to both of you. I really appreciate it. To the audience, thank you very much for joining us. I'm supposed to give you instructions to say that that you need to change to go to room number 4 to join the next session, Kidney Care Challenges and Opportunities in the Caribbean, Quality, Sustainability, and Equity of Access. And you'll find that by clicking on the live session at the top left of the WCN 21 portal under Program on the left side. So if you take a look at that, then hopefully you'll be able to go to the next session. Thanks so much for joining us, to everybody in the audience, and thank you so much again to the speakers and to my co-chair, Mary. It was lovely to meet all of you. So thank you.
I wish to welcome you all to this conference and this session of the conference on kidney care, challenges and opportunities in the Caribbean, quality, sustainability, and equity of access. I shall introduce the 3 speakers for this session. Dr. Ian Thomas, who will speak an overview of diversity of Caribbean regional resources for kidney care, a graduate of the University of the West Indies, Mona, Jamaica, residency and general nephrology fellowship at University of Miami, Jackson Memorial Hospital, subsequently did intervention nephrology and later transplant nephrology, and he works in Antigua and Barbuda in the West Indies at the Mount St. John Medical Center. Dr. Lorianne Fisher will speak on COVID-19 and kidney care in the Caribbean. She is a consultant nephrologist and intensivist at the University Hospital of the West Indies in Jamaica. She also graduated from the University of the West Indies, and she studied internal medicine and nephrology in the United States, being board certified in internal medicine and nephrology, and later Johns Hopkins University, being trained in critical care medicine. Dr. Adedamola Shoibo, who is the chief of nephrology at the Department of Medicine, University of the West Indies, University Hospital of the West Indies. He's also the head of the organ transplant unit, a senior lecturer with the University of the West Indies, and a consultant nephrologist with the University Hospital of the West Indies. I welcome them all, and we proceed with these presentations back to back.
Good day. It is a distinct honor to participate in this Kidney Policy Forum. Special thanks to the ISN and the Caribbean Institute of Nephrology for the invitation to speak. For the next few minutes, I'll give an overview of the diversity of Caribbean regional resources for kidney care. I have no conflicts of interest. The name Caribbean often conjures images of beautiful beaches lined with palm trees and friendly people. Some may even believe the Caribbean is completely homogeneous. It is true that there are many similarities, like the ubiquitous presence of carnivals and rum distilleries. And each year, collectively, we watch with anxiety as hurricanes roll across the Atlantic Ocean toward our region like giant bowling balls, ready to wreak unimaginable devastation. Yet the islands are different in several ways. The land and population sizes vary quite dramatically. Some islands have fewer than 10,000 inhabitants, while others have in excess of 10 million. Some are still overseas territories of European countries, while others are independent. Language differences also exist between the islands. There are actually 6 official languages, and this often serves as a barrier to communication. This was actually pulled from the Global Kidney Health Atlas. And if we look at our World Bank ranking, you will see that all the Caribbean countries, with perhaps the exception of Haiti, are classified as upper middle income or high income countries. But the truth is, many would argue that the islands are generally better described as small island developing states. Why? Well, we have small but growing populations, there are limited resources, susceptibility to natural disasters exist. We're heavily dependent on international trade. There's a high energy, telecommunication, and transportation costs. And this creates significant vulnerability to external shocks. Simultaneously, there is a high burden of kidney disease in the region due to lifestyle factors, which have created an explosion of obesity, hypertension, and diabetes. And also a large percentage of the population is of recent African ancestry, which has implications for ApoL1 associated kidney disease. Nevertheless, as signatories to the United Nations Sustainable Development Goals, we have committed ourselves to achieving good health and well-being for all by the year 2030. So how are we doing? Well, the Cuban kidney services are among the most comprehensive in the region. And quite importantly, services are provided free to all its citizens. And in fact, the story of Caribbean nephrology actually began in Cuba in the late 1950s, early 1960s. And that's when dialysis services were first offered. Subsequently, the first successful kidney transplants were performed in Cuba and in Jamaica in the year 1970. The other islands have closed the gap somewhat, but still there are significant challenges in the other islands. Chronic kidney disease early detection programs are still limited, and hence there is really an overemphasis on the treatment of end-stage kidney disease patients. The capacity for chronic dialysis is present in virtually all the islands, but it is limited. So in some instances, nephrologists are actually forced to reduce dialysis frequency to twice weekly, or in rare instances, even once weekly. Thankfully, in most of the islands, there's now a trend to development of transplant services. As a region, it is generally thought that there are a high density of nephrologists per million population, but this is really quite variable. Some islands have no nephrologists at all, while others have only one nephrologist. This, due to the small population size, actually translates into a high density of nephrologists. But this is very deceptive because with one nephrologist, it's very tenuous coverage. If that nephrologist becomes ill or has to travel on vacation or migrates for whatever reason, the entire population now is without nephrology services. The situation is actually more dire when we look at the status of pediatric nephrology. The specialists are essentially only present in the largest territories, and even there, with the exception of perhaps Cuba and Puerto Rico, the services are very limited. This also is from the Global Kidney Health Atlas. In fact, there are widespread shortages in the kidney care workforce across the region. We know that dialysis nurses are in short supply throughout the region, and this is worsened by the fact that they may be recruited to work in wealthier, developed countries. Additionally, there's the lack of availability of vascular access surgeons and interventional radiologists, which creates a tremendous challenge and an over-reliance on the use of hemodialysis catheters. This data was obtained by personal communication with the individual territories, and it shows that there's quite a wide range of prevalences of dialysis-treated end-stage kidney disease within our region. In some territories, there are fewer than 250 dialysis patients per million population, whereas in some of the wealthier countries like the Curacao of the Dutch Caribbean and the British Virgin Islands and US Virgin Islands, they're 2,000 to 2,500 per million dialysis patients per population. Montserrat is a British overseas territory, so that all the patients that develop end-stage kidney disease actually migrate to the United Kingdom. Affordability of medications is also an issue, as in some territories, patients pay completely out of pocket. One successful mechanism, however, that has been deployed is in the smaller Eastern Caribbean islands, there's pooled procurement of dialysis supplies, allowing us to obtain high quality but low cost medications. In the area of governance, there are also many challenges. There are few regulatory bodies which will limit the guidance of policies, and it also creates a barrier to ensure maintenance of best practices. There are few national kidney registries, and although the Caribbean Regional Registry has been set up, it is plagued by incomplete and inconsistent reporting of data by the individual territories. And as I mentioned earlier, although live donor transplants are being performed increasingly across the region, the number of islands with supporting legislation to support transplant is limited. In the area of health financing, it's quite variable. In some islands, patients are asked to pay out of pocket, but the fees fortunately are often waived for these patients. In other territories, there is a national health insurance plan, and in others, there's tremendous support from charity organizations. Like in Antigua here, there's an Antigua and Barbuda Renal Society, which contributes both to individual patient issues, but also has donated dialysis machines and other equipment to the dialysis unit. Here we actually have perhaps our youngest member. This is my 3-year-old son and his mom, my wife. So in summary, the Caribbean region is diverse. It's best thought of as a region of small island developing states, and accessibility, affordability, and quality of care vary substantially between the islands. Thank you.
Thank you, ISN, for inviting me to present today on COVID-19 and kidney care in the Caribbean. So the Caribbean is home to about 44 million people of varying ethnic admixtures, but similar socio-demographic and economic climate change susceptibilities. The first case of COVID-19 was recorded in the Caribbean in March 2020, and in the past year, about 539,000 cases have been recorded, resulting in almost 10,000 deaths. And the graph to your right, to your left of the screen, shows the distribution of cases, with Dominican Republic, Puerto Rico, and Cuba and Jamaica having a high burden of disease, as opposed to the smaller islands of the lesser and greater Ncds having less cases. There is an increasing burden of kidney disease in the Caribbean. In its most severe form of kidney disease, end-stage renal disease, the most common modality used to treat this condition is in-center hemodialysis. There have been challenges with COVID-19 and managing dialysis patients. So first of all, as you see in this picture, it's often very difficult to social distance. And especially in the Caribbean, the dialysis unit is seen as a place for social interaction, and social norms are in the Caribbean is to kind of gather very close together, especially in waiting areas while waiting for dialysis. And the actual space in a lot of dialysis units in the Caribbean is actually relatively small, with high amounts of interactions between patients. Patients with kidney disease are also a very high risk group, primarily because of immunocompromise, in addition to high index of comorbidities and often advanced age. There's also recurrent exposures. Although the most in-center hemodialysis, most commonly it's twice a week dialysis, unlike 3 times a week worldwide in about 60% of persons. 3 times a week dialysis still occurs in 30%. And again, this is an increased exposure risk. And because of all these reasons, they're a potential source of outbreak. Having recognized this, nephrologists throughout the region have had and nursing care throughout the region have had interventions to reduce COVID-19 risk in the dialysis units. So in most countries, there was isolation of COVID positive patients who were required dialysis. So were dialyzed at the last shift. Or there was in some countries, there was actually an isolation dialysis unit, such as in Barbados. There was increased dialysis shifts to reduce the numbers of persons per shift and therefore allow for social distancing. Reduce some of those people with 3 times a week dialysis to 2 times a week dialysis, again, to minimize risk of exposure. And we educated staff on COVID-19. A lot of the challenges faced, especially in the beginning of the pandemic, was lack of equity of access to personal protective equipment, PPE. There's lots of staff shortages as well as a reduction in staff morale due to less social interactions, increasing workload, and staff burnout. And of particular importance or unique to the Caribbean, it was lack of dialysis kind of machines for COVID positive patients, because oftentimes portable units were used, and there were limited portable units within the countries. In terms of chronic kidney disease in the Caribbean, although the exact prevalence of CKD is unknown, there's a high burden of chronic kidney disease risk factors. We know that diabetes, hypertension is increasing, as well as obesity is increasing in the Caribbean. Unfortunately, in this time, there's a reduction in ambulatory medicine. So closure of clinics in some countries in the initial phases of the pandemic, and in the cases of spikes, there was diversion of staffing to COVID-19. So this caused delays in kidney care, one, because of lockdown and stay-at-home orders, which disproportionately affected persons with kidney disease, as often older persons and persons with comorbidities were still to stay at home. There was also loss of income. Tourism is a major source of income in Caribbean countries, and due to lockdowns and travel restrictions, a lot of people lost incomes and therefore weren't able to continue with their care. There was also reduction in clinics and limited access to telemedicine, in addition to reduction in elective surgeries, again, to cope with the COVID pandemic, resulting in less creation of AV fistulas and access for dialysis. In terms of acute kidney injury, it's the most common cause or very common complication of COVID-19 infection, occurring in about a quarter of cases. There's limited data on AKI in the Caribbean, but based on preliminary data from a single center study in Jamaica, 114 persons had acute kidney injury based on KDOQA definitions, with 44% of them requiring dialysis, and 39% died. The details of this will kind of be discussed later in another presentation. Again, there were significant delays in dialysis, again, due to limited availability of dialysis machines, but also limited availability of staff. In terms of shifting gears a bit to vaccine access in the Caribbean, compared to high-income countries, Caribbean countries had less access to vaccination. Certainly, the COVAX initiative by World Health Organization to improve equity in access resulted in some vaccinations in Eastern Caribbean countries as of March 2021. And of course, there was a donation of 500,000 vaccinations from India to the region. We know that kidney disease is a high risk group for mortality from COVID-19, and therefore, efforts made to prioritize CKD patients because they're high risk, especially given limited vaccination amounts, and education on vaccination, especially in the Caribbean. There was also some hesitation in actually accepting vaccination, and educating persons on the importance of vaccinations were really important. So in summary, COVID-19 has had a significant impact on delivery and access to kidney care in the Caribbean. There have been challenges, certainly in PPE shortages and staff shortages, and access to CKD care, renal replacement therapy. However, moving forward, public health efforts focused on vaccination education, and improving access to medical care is going to be important in reducing the burden of kidney disease in the Caribbean. And thank you very much for my time. I welcome any questions.
First, I'd like to thank the organizers for this meeting, International Society of Nephrology and the Caribbean Institute of Nephrology, for inviting me to present. So we're going to be looking at the successes and challenges in kidney disease care in the Caribbean. And I do not have any conflict of interest, and I would like to thank the persons that are displayed. So what is kidney disease in the Caribbean? We're going to look at the renal disease. We're going to look at some of the challenges, and we're certainly going to look at the success stories and then some recommendation moving forward. Renal disease in the Caribbean. So this is a timeline that shows what has been happening between the 1970s and 2021 regarding kidney disease care. So we started the first dialysis, and then that's transplant in 1970. And then we moved on to developing the hemodialysis program at the University Hospital. And then we have, development in Trinidad in 1978. And then we have, concept of Caribbean Renal Registry. And then we had the first publication in 2004 on the registry that looked at the prevalence for Jamaica, and then in 2006 for the entire Caribbean, well, not the entire Caribbean, for English-speaking Caribbean. And then we have development of the web-based renal registry. We have conferences that was developed, and the disease donor program was started in 2010 in Trinidad. And in 2019 and 2020, Jamaica had 6 living donor kidney transplant. And of course, we started our disease donor program. So renal disease in the Caribbean, looking at Caribbean renal registry, the registry has the capacity to explore CKD, ESRD, prevalence. We can look at AKI, we can look at AKI on CKD, and this also includes looking at progression on a monthly, on a yearly basis, look at the causes of death, or even trends between the participating countries. So what about the challenges in kidney disease? We can look at challenges from an economic burden point of view, prevalence of risk factors, and brain drain. Now, economic burden of disease, we can look at direct costs or indirect costs. So direct costs are related to personnel, paying persons, the drugs that are needed, the laboratory support for kidney disease, and also the investigation that is also needed. When you also look at the burden from a replacement cost point of view, looking at infrastructure, equipment, dialysis, X-ray machines, consumables, and looking at the overheads to maintain a dialysis program or even a transplant program. And then we look at some of the indirect causes. And these are areas that have been of economic burden. What are the prevalence or risk factors? So Jamaican Health and Lifestyle Survey and other data from International Diabetes Federation throughout the Caribbean has shown that there's a rise in the prevalence of chronic non-communicable disease, some of which are causes of chronic kidney disease, so like type 2 diabetes, hypertension, obesity. Now, this is also been driven by poor control of these risk factors. So in terms of percentage of persons who are controlled with diabetes and medication adherence. Then we have genetic risk factors, so like APOL1 gene, the prevalence of sickle cell disease, prevalence of SLE and polycystic kidney disease. So all of these risk factors will also lead to CKD increase in prevalence. And then you have disease-related complications or treatment-related risk factors. So when we look at chronic communicable disease like HIV, effective treatment of those diseases has led to development of other lifestyle-related risk factors, so like diabetes, hypertension, and some of them are actually related to the medication. And in general, we have an aging population with increased life expectancy, so there will be an increase in risk factors. What about brain drain? Mass migration of specialist care. So not just doctors, but nurses, dialysis technicians, biotechnicians, all these persons who are integral part of maintaining a good, solid renal replacement program or dialysis program or nephrology program. They are all moving to areas that have had better offer. Learning opportunities and advancement opportunity, which are much more available in other first world countries or in first world countries, has led to movement also, specialist training that are available overseas. Now, personal goal and drive of some of our colleagues has also led to mass migration because of their own personal gain or compensation or whatever is they figure that is attractive to them, has led to this mass movement. So what about the success stories that we have? So we have an increasing number of specialists, okay? So we have an increasing number of nephrologists. Nephrology training program has been incorporated in DM internal medicine and pediatric program. We have nephrology nursing program with participation from other places throughout the Caribbean. We send their nurses and doctors to have to participate in training. Also, the availability of drugs on formulary. So within the Caribbean, there's some countries that healthcare system is supported by the government, Jamaica, Trinidad and Tobago, and most of the Caribbean countries, but also some of the drugs that are needed have been supported by the government or has sort of made it a little bit cheaper for the patient to have access to these drugs.
And that has helped. The pediatric program, especially, that's developed in Jamaica and has led to, offering hemodialysis and peritoneal dialysis only so far, the University Hospital of the West Indies, but we do get referrals from other countries for initiation of these bigger children, I should say, maybe the ones in their tens and teens, kidney biopsy and stuff, and some other stuff have been made available within the Caribbean. What about healthcare policy? So development of a transplant program, living donor kidney program, disease organ donor procurement and implantation, and of course, getting an MOU signed between countries. This has facilitated, the development of a robust kidney program within the Caribbean. And then we have the indirect ones, so like smoking cessation in public places campaign, and which has been adopted throughout most of the English-speaking Caribbean. Pediatric nephrologists have created a management guideline for pediatricians and also for medical practitioners locally, and this has been shared with other Caribbean countries to looking for screening and also how to care for patients in terms of dialysis and transplantation centers. Development of a transplant program that has been very key with increased collaboration, and overall we have active living donor kidney transplant in Jamaica, Barbados, and Trinidad. We've established disease donor program, and we have establishment of CKD registry in some of the Caribbean countries with the aim of looking at risk factors for prevalence. There's the option of referral, which has been made easy for renal transplantation cases, especially the complex ones, and of course for pediatric cases. And we can boast also that we've had our first report looking at the role of toxic elements on chronic kidney disease, first looked at in Jamaica, and that will subsequently be looked at in places like St. Vincent and all the other Caribbean countries to see some of the contributing effect to kidney disease. So what is the way forward? We need to establish more sister center partnership. We have that established with overseas countries already, but we need to look at partnering within the Caribbean, within various institutions and hospitals within the Caribbean. We need to look at screening for children during pregnancy to try and prevent those diseases that can occur during fetal development that are amenable to early treatment and better outcome. We need to look at CKD and the risk factor prevalences in some of the Caribbean countries that have not been established. And this is where the role of Caribbean Renal Registry, along with Caribbean Nephrology, to drive this, looking at epidemiological data that can inform decision and policy making. National government sponsorship program for pediatric renal replacement therapy, including dialysis and transplantation, and helping to drive this policy forward. Disease donor program that needs to be initiated. In some of the countries, we've already started in Jamaica. Trinidad and Tobago have started theirs for the past 10 years, but we need to have robust legislation, maybe throughout the entire Caribbean, with organ sharing MOUs being done, and also looking at some of the ways to overcome barriers to organ transplantation. I thank you very much. And I just, again, like to thank the organizers for inviting me to be able to share some of the successes and challenges in the Caribbean. Thank you.
Thank you very much indeed, all of you. I think we have 1 minute or two for questions, if there are any. So, okay, so some of you who may have questions, you can still post your questions. They will be answered over the next few weeks on the live networking group on the WCN 21 portal. You just click on live networking. So I don't see any questions coming across. If not, let me just say, if they want to know, let me just say though that there's been a lot of mention about the brain drain, and as Dr. Shoibo mentioned, the University of the West Indies has been very helpful to us in accommodating or starting a fellowship in clinical nephrology, which is a university program which spans all the campuses of the University of the West Indies. Unfortunately, it's a full fee-paying program, and persons have to find the money to pay for it. And they may not have a paying job, they may have an honorary job. If there are no questions, I would then want to ask attendees that they need to change the room and go to room 6 to join the next session. Kidney Care, Challenges and Opportunities in the USA, Quality, Sustainability, and Equity of Access. You can just click on live sessions at the top left side of the WCN 21 portal, or on the program on the left side of WCN 21 portal. I thank you all again. I thank ISN. This was a most interesting session. Thank you all.
Welcome, everyone. Welcome to the Challenges and Opportunities in the United States of America session. We will have 2 speakers during this session. I'll introduce the first of them. The first is Dr. Suzanne Nicholas, who is an Associate Professor of Medicine and Clinical Hypertension Specialist at the David Geffen School of Medicine at UCLA. Where she's in the Department of Medicine and Division of Nephrology. Dr. Nicholas's research has been around diabetic kidney disease pathogenesis, as well as in chronic kidney disease health disparities. She has published over 100 publications in this area. She was a Robert Wood Johnson Fellow and received the Minority Access National Role Model Faculty Researcher Award. Her topic will be the current state of funding, care, and access to kidney services in the United States. Dr. Nicholas.
Hello, everyone. And thanks, Neil, for the introduction, and thanks to the organizers for the opportunity to participate in this Global Kidney Policy Forum. These are my disclosures. And I want to begin with a view of the landscape of kidney disease in the United States. Currently, there are 37 million Americans with kidney disease, and every year, 100,000 people die with kidney failure at a rate that is 2.5 times that of breast cancer. Every day, 12 people die waiting for a kidney transplant. And when it comes to spending, 1 in every 5 Medicare dollars is spent on kidney disease patients, accounting for more than $114 billion in 2016. And even with these already staggering numbers, there are still notable disparities in kidney disease prevalence and consequences that have been primarily based on historic racial and ethnic inequities in the US, which in recent times have become more pronounced in a manner that has raised the consciousness of many. And it's important for us to be aware of these disparities, as it is anticipated that these individuals defined here as people of color will increase to 52% of our population compared to 39% in 2016. So when we talk about the current funding of kidney disease care and access, we really want to understand the landscape of the disparities of chronic kidney disease in the US. And these disparities in CKD in the US are significant, affecting African Americans primarily, who make up 13% of the US population, but have a higher prevalence of chronic kidney disease, accounting for 16% compared to 13% for non-Hispanic whites. In addition, African Americans have a threefold higher risk of progressing to kidney failure, accounting for up to 35% of individuals with kidney failure, and typically occurring at an earlier age. Further, African Americans have a 2 to 4-fold greater incidence of kidney failure compared to whites. Unfortunately, the COVID-19 pandemic has exacerbated disparities in the US, and this is on top of the racial bias that already existed in healthcare, such that people of color were more likely to not receive access to testing, were more likely to live in poor housing, making social distancing difficult. They're more likely to be exposed to pollutants and to have a pre-existing condition such as chronic kidney disease, and they were more likely to be an essential worker. And all of these factors significantly contribute to the increase in severity of COVID-19 infections. And this became most apparent very early in the pandemic when it was observed that Black African Americans made up the highest proportion of individuals who were infected with COVID-19 and were either not hospitalized or who were known to have died from the disease. And one would surmise that with these disparities, that every effort would be made to ensure that these vulnerable populations receive every resource to decrease the severity of their illnesses. But in many states, the proportion of individuals who were Black and were healthcare workers, shown here in the black dots, was significantly higher than the proportion of individuals who were state residents who were Black, shown here in the blue dots. And even more important and striking is the fact that the share of vaccinated individuals who were Black was dismally and consistently low across many states. And indeed, there are a number of factors that can have contributed to these disparities. And we can also use these factors as targets for achieving health equity for chronic kidney disease. And these include not only behavioral and environmental, but also biologic, as well as clinical health policies and healthcare delivery. And if all of these factors are adequately addressed, we can indeed achieve health equity for chronic kidney disease and kidney care. The Department of Health and Human Services, or DHHS, under the executive branch of our government, is responsible for all aspects of healthcare. And in particular, the Centers for Medicare and Medicaid Services, or CMS, is responsible for providing services for kidney patients who receive renal replacement therapy in the form of dialysis or kidney transplantation, as well as individuals who are 65 years and older, which, as you know, make up a large percentage of our chronic kidney disease patients. So the DHHS budget proposal, which was submitted for fiscal year 2021, early in the spring of 2020, requested $94.5 billion for discretionary funding and $1.3 trillion for mandatory funding to cover combined Medicare and Medicaid expenses of about 86%. In response to the president's executive order, which focused on putting America's health first, the DHHS budget was focused on a number of kidney-related issues, including medical technology, as well as paying for providers for their the time that they spend with patients compared to the time spent on procedures on paperwork, and also to help healthcare providers reach their the top of their licensed, such as nurses, for example. In addition, the DHHS budget requested $39 million to cover the Advancing American Kidney Health Initiative that was enacted in 2019 to, one, reduce Americans developing kidney failure by 25% by the year 2030, and to increase the number of new kidney failure patients receiving home dialysis or kidney transplant up to 80% by the year 2025, and also to double the number of kidneys available for transplants by the year 2030. And all of these initiatives were very important in order to address the inequities, some of which I have already mentioned, such as the almost fourfold higher prevalence of kidney failure in African Americans compared to whites. In addition, Blacks are less likely to have home dialysis and are less likely to get preemptive transplants. And this has dated as far back as 2000 and has continued even after the initiation of the new kidney allocation system, which was designed to increase the numbers of kidneys that were available for transplants. And as you see, the increase in preemptive transplants available to Black and African Americans is barely discernible compared to the continued increase in preemptive transplants for whites. Some of this can be explained by disparities in preemptive transplants according to payer. For example, those who are receiving the majority of preemptive transplants tend to have more private primary insurance payers compared to those at the bottom of the profile who tend to have Medicare as their primary insurance payer. And as such, the DHHS budget for fiscal year 2021 requested an additional $59 million for the Office of Minority Health, which is responsible for all of the related services across the DHHS, as well as $31 million for the organ transplantation program and $18 million for the organ procurement transplantation network, and another $15 million for the Preparedness and Response Initiative. And I would caution you that with the new administration, which has a focus to build back better, that is much more comprehensive to specifically increase health equity, these numbers are being adjusted. For example, the $310 million requested for pandemic influenza coverage has now been increased to a request for over $1.9 trillion. And so all of these budget amounts are being robustly deliberated in Congress in order to arrive at a final resolution. In terms of funding for NIDDK, which covers kidney research infrastructure, the DHHS budget for fiscal year 2021 had anticipated a decrease across all of the different areas. But even now, these numbers are being discussed, and it's expected by the time of resolution that there will be an increase in budget across for these services. So I want to end with a call to action to ensure that we optimally address CKD and COVID-19 disparities in the US. Actions towards CKD health equity for African Americans will include increases in testing for chronic kidney disease, increases in the number of people of color in the nephrology workforce, increases in awareness and education of providers and patients, increases in research funding in areas that need additional focus, such as acute kidney injury, increases in access to kidney transplantation, as well as strategies to promote patient care, particularly around new therapies, such as under the Kidney Health Initiative that my colleague will discuss next. And action towards equal access to COVID-19 care for African Americans include increases in testing and contact tracing, particularly with the new COVID-19 strains, increases in vaccinations to high-risk individuals, and increases in the number of ethnic minorities. I would say in all clinical trials, but especially in the COVID-19 clinical trials. So I'll end here and thank you for your attention.
Well, thank you, Dr. Nichols, for that enlightening presentation. Our next speaker is Ms. Glenda Roberts. Ms. Roberts is the Director of External Relations and Patient Engagement for the Kidney Research Institute, which is a collaboration between Northwest Kidney Centers and the University of Washington School of Medicine. That's dedicated to transforming the lives of people with kidney disease through innovation and discovery. Prior to Ms. Roberts being with the University of Washington, she was an information technology executive with over 35 years of experience working in such corporations such as General Electric, Microsoft, and Johnson & Johnson. Before going on to dialysis, Ms. Roberts managed the progression of her disease through her career via diet and exercise for over 40 years. And since her transplant in 2010, she has completed 8 half marathons. Ms. Roberts is going to talk to us about patient perspectives and the Kidney Health Initiative. Ms. Roberts.
Thank you for having me. I'm Glenda Roberts, and it is a pleasure to be here to give you the patient perspective on quality of care, access, and sustainability. These are my disclosures. You know, long before I got involved with kidney research or the Center for Dialysis Innovation, my first career was in the information technology industry. I actually started out as a software developer at Shell Oil Company. It was my first job out of college. And Shell had made me an offer, and I had turned down all other offers, but the offer was contingent on completing a physical. I got a call from Shell saying that they wouldn't be able to hire me because I had too much protein in my urine. I called my mom, and she told me to come home to Fort Worth, and she took me to a urologist. He did a number of different tests, but he was not able to produce the exact results that they had reported to Shell, and he wrote a letter to them saying that they should hire me. And he said, as soon as they hire you, you should go on dialysis. I said, dialysis? What's dialysis? And he proceeded to explain it, and it sounded horrible. And he didn't really do a very good job because he wasn't accustomed to patients questioning his judgment. So I said, so what are my other options? He said, well, you can try diet and exercise, but most people aren't able to do that. Now, the sad part of this story is some 50 years later, dialysis, lifestyle management, and now transplant are the primary treatments for people that are living with kidney disease. We're starting to see some progress as it relates to drugs related to SGLT2 inhibitors, but the jury is still out on that. So the thing that excites me so much about the Kidney Health Initiative is that they're focused on research to understand the causes and possible prevention of kidney disease, educating the public and people at risk for kidney disease, and developing policies and standards that will drive the integration and development of solutions that help people live their best life with kidney disease. Now, KEY, or the Kidney Health Initiative, is a public-private partnership between the American Society of Nephrology and the Food and Drug Administration. The motivation was to catalyze innovations for the development of patient-centered therapies for people with kidney disease. We are a pre-competitive collaborative community, and we develop a number of tools, projects, and publications and more to educate people about kidney health disease, kidney solutions, and kidney treatments. And the most important thing is that patients are at the center of the collaborative. We are an equal partner with all of the other stakeholders. Now, this is an example of the education effort around KEY. You'll hear me talk later about the technology roadmap for innovative approaches to renal replacement therapy. This is the patient edition. The same 4 criteria: enhanced dialysis, portable and wearable solutions, implantable and biohybrid, as well as regenerated kidneys, are the solution approaches that are a part of the roadmap. But in this version of the roadmap, we focus on the benefits that are important to the patient. You know, one of the things that Jonathan Himmelfarb always says to me is dialysis replaces the burden of the disease with the burden of the treatment. I have been on in-center dialysis. I used to go 3 days a week, 4 hours a day. That's 12 hours. I was sick for 8 to 10 hours after each dialysis treatment. And if you're conservative, that's another 12 hours. So for 36 hours a week, I was essentially wiped out. That's a job. Most people who are on in-center dialysis experience physical as well as mental symptoms. Another concern about dialysis is that it is really a drain on the water system. It requires a lot of high quality water. And you'll notice you can dialyze 1,481 patients for twice as much water as it takes to support the same number of households in King County. That's in the Seattle area, which is where I live. Sadly, in 2010, only 21% of the world's population was able to get kidney replacement therapy, and that's projected to increase to 27% by 2030. But it's still horrible. And for people who are in low income and middle income countries, the likelihood of you being able to get dialysis treatment is substantially reduced because of the cost and scarcity of water. Now, a lot of people in the US are talking about trying to get more people to consider home dialysis because it has a lower cost. And I did home dialysis, the peritoneal type, like this gentleman who happens to live in the Seattle area. Each month, I got 93 boxes delivered to my house. And I live in a generous space, so I didn't have to do what he does. He lives in a 1-bedroom apartment, and he puts half the boxes on one side of the bed and the other half of the boxes on the other side of the bed. And so he is constantly reminded that he is sick and on dialysis. And there's also a cost that's associated with this because you have to recycle all the boxes and the bags and the tubes, and it drives up the cost of recycling. And that is not a cost that the patient is able to recover. Sadly, 93% of people who are on dialysis are classified as disabled because it takes so much time to be successful in taking these treatments. And after 5 years, roughly 50% of people on dialysis are likely to die. The cost of dialysis is $93,000 per year per patient in the US, and most countries just can't afford that. Now, Willem Kalf, who created the original dialysis machine, said that if we're to keep patients alive and healthy via an artificial mean, that it should be a good life and an enjoyable life. Let me be the first to tell you, dialysis is not a good life. And for a number of reasons, people have not been able to move forward with technology and innovation, in part because investors could not see how they were going to recover their investment or get through the long FDA process. Well, in 2012, the federal government had an aha moment and decided to focus on kidney disease, and decided not to focus on kidney disease, but rather to focus on kidney health. And that led to the formation of the Kidney Health Initiative and this roadmap. Now, there are 110 people in the consortium, and I encourage you to go to this website if you're interested in collaborating with any of them. And any member of our Kidney Health Initiative Patient and Family Partnership Council will be glad to consult with you so that you have patient input. Like the roadmap that I showed you earlier, this is the Innovators Roadmap. It focuses on research and development. It identifies multiple parallel pathways to develop solutions that will give patients a better quality of life. And at the end of the day, what's really important is to focus on the patient priorities, bring together the relevant stakeholders, produce low-cost, cost-effective green solutions that give patients their best life. Thank you very much.
Well, thank you, Ms. Roberts, for sharing that exciting initiative with new possibilities for the future. So now it's time for our question and answer session. And I'll lead off with the first question. And this is for Dr. Nicholas. You referenced the shocking disparities between different ethnic groups and how the COVID pandemic has exacerbated them. The new administration in the US does appear to be cognizant of these disparities and reacting to them. But is there anything more they could do to tackle them?
Thank you, Neil. And that's a really great question. I think that collectively, we're all very pleased about the direction that the new administration has taken in terms of addressing the issues around making vaccines available to everyone, but with a specific focus on our vulnerable populations. And I think that's really great. However, that there are still some issues that I think do need to be addressed with maybe a little bit more emphasis. And one of the issues right now is around vaccine hesitancy. I think we've all been hearing more about that lately. And some of the things that can be done really is to provide the resources so that we can have a better understanding about the factors that contribute to vaccine hesitancy. We're familiar with the past history of mistrust that has been engendered in care for Black patients, Black African-American patients in the Tuskegee study in the past. And I think it's unfortunate, though, that because of this history and the mistrust that it has engendered, we now have a bit of an uphill battle. And you can recall from earlier this morning, our keynote speaker, Timothy Caulfield, talked about misinformation. And it's because of this type of history, it makes it so much easier for our patients to accept this misinformation. And so we really need to address this and to provide the education and to repeat that education over and over again around the things that can allay the fears and concerns of the individuals who really would benefit the most from the vaccinations. They need to know more information about how the vaccines have been prepared, and they need to have better access to these vaccines. In addition, there are a couple other things I could mention in terms of getting more information at how patients respond to vaccines. You know, what's the longevity of the immunity that we create or we build when we're vaccinated? Are our minority populations building the type of immunity that will have sustained immunity? We don't know that, but it's something that we do need to find out about. In addition, the prolonged effects and complications from having been infected with COVID becomes difficult. And we need to understand whether these populations are having longer time with these complications and what ways we can help to alleviate that. And these are some things, and there's more, but I think these are the things that I see that require some priority response and targeting.
Well, thank you. That is really, really important. Let me turn to you, Ms. Roberts. Those were really exciting things about the Kidney Health Initiative's roadmap for tomorrow. All that innovation in enhanced dialysis, portable wearable devices, implantable projects, and the regenerative kidney. But as we know in the past, sometimes those there are a lot of obstacles to having that innovation adopted and used. So I ask you, what do you think some of those obstacles might be, and what can we do to overcome them?
Thank you, Neil. That's an excellent question. As we all know, there have been no innovations for all intent and purposes over the last 60 years for people that are living with kidney disease. People were functioning in silos. It was difficult to get funding, and there were no standards. The Kidney Health Initiative has helped to define the standard so that it is easier for people to collaborate and work together. And it gives funders a vision for how they might be able to recover their investment, because they see that organizations like the Food and Drug Administration, Medicare and Medicaid are all involved in the process. And when we look at the opportunities that are being considered under the KidneyX program, we see that increasingly the roadmap is being used as the standard to evaluate all of the competitive offerings. And what this has led to is greater collaboration from different innovators to try and develop solutions that appeal to patients.
Well, thank you, Ms. Roberts. That's also exceedingly important. So that's all the time we have. There are a lot of questions and answers, and we will try to answer those via social media. At the end of the session, you should, I want to remind you that you should go to room 4 where the discussion will continue. And you can find that by clicking on the live sessions button at the top left of the WCN 21 portal. So thank you for being with us today in this stimulating session.
Welcome everyone once again to another session of the 2021 Global Kidney Policy Forum. We are staying with our focus on North America, solutions, and before that, obviously challenges. So we are going to discuss 2 topics, and we have 2 real experts to discuss those topics, and I really look forward to hearing from both of them. They are old friends, and they never cease to amaze me when they present their new data and their thinking. We'll start with Dr. Shuchi Anand, who is a nephrologist and clinical researcher at Stanford University. She has an interest in caring for patients with a broad range of kidney diseases, but has had a long-standing interest on what we are calling the chronic kidney disease of uncertain etiology. She has a number of active projects in collaboration with Santa Clara Valley Medical Center, Emory University, Center for Chronic Disease Control in India, and Kandy Teaching Hospitals in Sri Lanka. She is building clinical expertise in tubulointerstitial disease, and she is going to talk to us about CKDU, both global trends and the problem in North America. Shuchi, over to you.
Hello, everyone, and thank you for the opportunity to talk to you about chronic kidney disease of undetermined origins in North America. I have no relevant disclosures. So I wanted to start with a high-level overview of the state of knowledge on cause of kidney disease. And throughout the world, we have 4 major causes of kidney disease into which most registries classify kidney disease, and clinicians also tend to classify kidney disease. One is diabetes, and that's the largest share. The second is high blood pressure, and then glomerular disease, and lastly, a genetic cause, or usually autosomal polycystic kidney disease. But even among the 2 largest buckets into which kidney disease is classified, there is a share of people who likely have another cause of kidney disease, but because biopsy is not standard, their kidney disease is misattributed to these 2 particular causes, and that share is probably larger in people with high blood pressure. In addition to that, there are kidney diseases, a substantial portion of kidney disease that has no cause identified, largely because patients present at late stages and there are no diagnostic capabilities remaining to help diagnose cause of kidney disease at that stage. But we're also increasingly recognizing that some kidney disease is due to underdiagnosed genetic causes, and that some kidney disease that is atypical in its presentation may be specifically a diagnosis of CKDU, which the term of which I'm using to refer to a regional nephropathy in agricultural workers. And then I also want to hearken and highlight the fact that there's likely a share of kidney disease, the causes of which we have yet to discover. The future discoveries will lead us to specific causes that are as yet unknown. And this data sort of mirrors what we just spoke and reflects it for North America. And you can see that diabetes, glomerular disease, and polycystic kidney disease, as well as hypertension, are the 4 largest causes of kidney disease based on registry data on end-stage kidney disease from Canada, US, and the Jamaica and Trinidad and Tobago. And there is about a range of between 5 to 38% of kidney disease specifically being labeled as unknown in these registries. What I wanted to highlight here is the fact that how much of kidney disease is labeled unknown likely depends on clinical practice in that region. So for example, in Trinidad and Tobago, there is a higher tendency to label kidney disease as unclassified, whereas in Jamaica, perhaps there's a tendency to label it as related to high blood pressure. And, why do I highlight this association between unknown kidney disease and high blood pressure? Many nephrologists in the audience will know this story of APOL1 nephropathy in African Americans. And this is one major exemplary reason for why we are suspicious of high blood pressure as a cause of kidney disease. So for decades, we had known that African Americans had a higher risk of kidney disease, and that risk was attributed to high blood pressure. But due to a high index of clinical suspicion and multiple years of investigation for a genetic cause, we now know that 70% of non-diabetic kidney failure in African Americans is actually due to a genetic polymorphism in the APOL1 protein. So, I think that's why the cause of undetermined kidney disease and identifying specific causes of kidney disease is really on the agenda for researchers and nephrologists, but patients also are engaged in this topic. When I spoke to Richard Knight, who many in the audience may know as an advocate for kidney patients in North America, he really took me back to his own story of how he was diagnosed with dipstick protein in his urine in the 1990s. There was no cause specifically identified. And by 2004, he had to start dialysis. And so he really astutely links early detection and identification of cause to creating specific therapies, or to having the availability of specific therapies that delay progression and prolong kidney life, which is the ultimate goal for most patients. And that's why they're intimately engaged and want to support this area of research. In the US as well, this is another set of data showing that people with unknown kidney disease or people in whom kidney disease is attributed to high blood pressure tend to have a greater proportion of people who have not sought care prior to their diagnosis. So this is the advanced presentation box that I was showing you, that for up to 40% of people in the US with these diagnoses have not had prior care. So there are 2 major pillars under which investigations into cause of kidney disease are currently being focused. One is a continued focus on genetic causes and characterizing genetic causes of kidney disease. And there are multiple papers that have shown the yield of genetic investigations, of which this is the most prominent example. And in this cohort of up to 3,000 people, they did a whole exome sequencing and found that 9% of them had a genetic cause identified. And if they had been labeled as having a nephropathy of unknown origin, 17% of them could have a genetic cause identified. And similar data have emerged from other cohorts, some of whom were enriched for people with undiagnosed kidney disease and had higher diagnostic yield. There's also reasons for concern about an environmental cause of kidney disease. And here I'm specifically focusing on this disease called CKDU, which is a disease occurring in the sugarcane fields in Nicaragua and the rice paddy fields in southern India, as well as in Sri Lanka, where high numbers of people are being affected and actually are dying of a kidney disease that is unknown etiology as yet. So these are data showing the remarkable increase in death from kidney disease in Mesoamerica. As well, in Sri Lanka, you can see that up to 20% of people know a family member with kidney disease there. So these are hotspots of kidney disease throughout the world, and there's suspicion that some sort of penetrance of this kidney disease is likely also occurring in the US. So these are data from the USRDS mapping the incidence of kidney disease after adjusting for age, sex, and race ethnicity. And you can see that there are areas that are dark blue that indicate high incidence of end-stage kidney disease. Some of these areas actually also correspond with areas of agricultural activity in the US. And several teams are working to investigate these particular areas. We've done a high-level investigation in which we looked at end-stage kidney disease and that we termed undefined if it was a younger person in whom the cause had been attributed to high blood pressure or no cause had been defined. And we found that there were clusters of these people with undefined kidney disease living throughout California, but more likely to be clustered within the Central Valley, where we also found evidence of high level of groundwater nitrate, which is an indicator of of agricultural activity. Similarly, another group took the data from the agricultural health study, which has over 55,000 men enrolled, and looked at incident end-stage kidney disease and found that if someone had visited a doctor for symptoms of pesticide use, they had a twofold higher risk for end-stage kidney disease. And if they had been hospitalized with concerns for pesticide toxicity, they had a threefold higher risk of end-stage kidney disease. There are other environmental exposures under investigation as well. The air pollution being the most prominent example. This was a study linking data from the VA in the US to particulate air matter concentrations and found higher incidence of CKD and end-stage kidney disease in areas of high air pollution. So the two, in summary, the two sort of content areas of investigation are genetic as well as environmental or occupational. And what's in our toolkit to work within these two areas is one, early detection, which the patients are very interested and engaged in. Two, multidisciplinary investigations. And three, tissue diagnosis. And lastly, recruitment of diverse cohorts to enrich our understanding of causes of kidney disease. So here is the most prominent example of tissue diagnosis and prioritizing tissue diagnosis. This is from the Kidney Precision Medicine Project, which was a project launched in 2017 by the US NIDDK after patient engagement in a scientific workshop to elicit how precision medicine can be applied to kidney disease. And you can see they honed in on biopsies, and they really want to get tissue diagnosis to identify molecular bases of kidney disease so that they can create direct therapies for the pathways that are identified to be pathological. And they're actually focused in the CKD arm on enrolling people with diabetes and high blood pressure because of the concern that some of them may have subtypes of kidney disease that are unidentified, and to increase the use of biopsies in these patients. Also in the US, there are multi-ethnic cohorts that are being launched or have been launched to investigate progression in kidney disease. So the Hispanic CRIC study is one of the most prominent examples of this, in which they, one of their key findings was that Hispanic participants had a faster rate of kidney function decline compared with even non-Hispanic Blacks or non-Hispanic whites. And so this is the type of work that will argue for more investigations, whether they be genetic or occupational and environmental, in this subpopulation. And similarly, there is a now American Indian or Native American cohort that is being launched to investigate rates of kidney function decline within that subpopulation as well. And in Canada, you may have heard this message already. There's a twofold higher risk for stage 4 kidney disease among the Aboriginal population, and twofold higher risk for end-stage kidney disease, and 77% higher risk for death with kidney disease. There's a whole body of literature investigating why this may be, but the cause yet remains undetermined. So I just want to end by summarizing that, as a field, and especially in North America, we are getting more interested in determining a specific cause of kidney disease. This is a priority for our patients as well. And the currently 2 major areas of investigations are genetic and environmental or occupational. And we have a growing toolkit to investigate causes, but the 2 sort of major pillars are tissue-based diagnosis and diverse cohorts and diverse populations to enrich our understanding of rates of progression and subtypes of disease. Thank you for your time.
Thank you very much, Shruti, for that exposition of this problem, which we typically thought was an issue of developing countries, agricultural economies, and so on, but you have convincingly demonstrated that we need to get serious in looking for it elsewhere in the world as well. And I'm sure that you will continue your dogged pursuit of this particular entity. Thank you for that. Now we move to really the other end of the spectrum of kidney disease, and we'll talk about kidney replacement therapy. And we are going to hear about initiatives to improve access to transplantation in North America from Professor John Gill. Professor John Gill is a fellow of American Society of Transplantation and a professor of medicine with tenure at the University of British Columbia in St. Paul's Hospital. And he is not happy that he is not in Montreal right now. John is an active researcher whose diverse research interests include clinical outcome in kidney transplantation, access to care, clinical trials, health services research, and research ethics. He is the president-elect of the American Society of Nephrology. So let's hear from John.
Hello, my name is John Gill. I'm a professor of medicine at the University of British Columbia in Vancouver, Canada. I'd like to thank the organizers for this opportunity to present today. I have no financial disclosures relevant for this presentation. This first slide shows the cumulative incidence of waitlisting or transplantation among incident kidney failure patients in the United States over a 20-year time period. The different colored curves correspond to the 5-year time periods between 1997 and 2016. Reading boxes from left to right, you can see that there's been no substantive increase in the outcome of preemptive transplantation or the combined outcome of transplantation or waitlisting at 1, 2, 3, or 4 years after the initiation of dialysis. This suggests that policy changes over the last 20 years have had minimal effect on access to transplantation. This slide shows the steps a patient must negotiate to gain access to transplantation. Patients must be referred to a kidney transplant center and complete the transplant evaluation process. Patients are then waitlisted for transplantation and receive transplants from a deceased donor based on strict organ allocation rules. It's clear that most of the variability in access to transplantation for individual patients occurs prior to waitlisting, as there is no requirement to refer patients for transplantation, and there is heterogeneity in the acceptance practices of patients onto the kidney transplant waiting list in individual centers. Once patients are waitlisted, there is much less variability in access to organs because they are allocated according to strict allocation rules. This slide shows the variability for referral for transplantation in Canada among incident dialysis patients by province per 100 patient years of dialysis. As you can see, there is a nearly threefold variation between provinces in referral for transplantation. This next slide shows differences in referral for transplantation between dialysis facilities in the state of Georgia. Remarkably, some centers had absolutely no referrals for transplantation. They don't even register on the graph. Whereas other centers have over 80% referral of incident patients for dialysis. Numerous studies have also shown that referral for transplantation is lower in patients from racialized communities and from communities with lower socioeconomic status. Now, a number of strategies to improve referral for transplantation have been implemented. Requiring dialysis providers to record whether transplantation has been discussed with incident dialysis patients has been implemented in the United States. This strategy has not had much impact as there is no measure of the quality of the counseling provided to individual patients. Recently, there's been consideration of financial incentives or penalties to dialysis providers to increase referrals for transplantation in the United States. Academic scholars have advocated for mandate referral for all patients, as well as collection of national data on referral for transplantation, which is not currently done. Progressive organ allocation policies have been implemented to minimize disparities in access to transplantation among waitlist candidates. Notably, changes introduced in 2014 to increase access for highly sensitized patients were implemented. To improve equity for patients with late referral, the organ allocation policy was changed so that waiting time would be calculated from the date of the first dialysis treatment among non-preemptively waitlisted patients. To address geographic differences in waiting time for deceased donor transplantation in the United States, donor service area was removed from organ allocation policy. This slide shows the increase in access to transplantation among highly sensitized patients as a result of a change in kidney allocation policy in 2014. This next slide shows the increase in transplantation for patients who were on dialysis for more than a decade. The new policy to calculate waiting time from the start of dialysis rather than the date of waitlisting allowed these patients to rapidly receive transplants. It's important to note that changes in organ allocation policy do not increase overall access to transplantation, but rather they minimize disparities in access to transplantation. The only way to increase access to transplantation is to either increase the supply of transplantable kidneys or to decrease the demand for transplantation. There have been a number of initiatives to remove financial incentives to living donation. These include reimbursing out-of-pocket expenses and reimbursement of lost wages during the convalescence period after living donor surgery. The Living Donor Protection Act was recently introduced into Congress. This bill aims to eliminate discrimination against living donors with regards to insurance and employment status. I just want to highlight in this slide a new program to eliminate financial disincentives to living donors. The American and Canadian Society of Transplantation have teamed up to recently launch the Living Donor Circle of Excellence. This is a corporate recognition program that celebrates employers that adopt a human resources policy to cover lost wages for employees who choose to be a living donor. Kidney pair donation programs have advanced a number of initiatives to increase access to transplantation for patients who have a medically suitable but biologically incompatible living donor. This includes the use of voucher donors and the use of compatible pairs, as well as the shipping of organs to eliminate the need for donors to travel. The use of voucher donors in KPD programs is increasing. A voucher donor was first described as an individual who donated in advance for a patient who is not yet ready for a transplant. The patient would subsequently receive a kidney from the living donor, from a living donor through the program. A family voucher is something new. This is someone who donates in advance, but the donor does not have anybody who needs a transplant. Instead, the donor is able to name 5 individuals who would receive a living donor from the program in the event that they needed a transplant in the future. This is data from the National Kidney Register in the US, which shows the increase in the use of voucher donors, which has significantly increased KPD transplants. This slide shows the use of compatible pairs in kidney donor programs. A compatible donor and recipient pair do not need to participate in the KPD program as the donor and recipient are biologically compatible, but they choose to participate in the program for other reasons. The potential benefits for a compatible pair include finding a younger donor or a better size or HLA matched donor kidney for the recipient. Incompatible pairs obviously benefit because more potential donors participating in the KPD program increases their probability of finding a matching donor. Reciprocity-based studies to increase participation of compatible pairs in KPD is now under consideration. For example, in recognition for their participation in the KPD program, the patient of a compatible pair would be given some priority for a repeat deceased donor transplant in the event the first living donor transplant failed. There are a number of strategies to increase the supply of deceased donor kidneys, including increasing donations after circulatory death through sharing of best practices, use of organs at risk for infectious disease transmission through the use of nucleic acid testing and protocols to increase the use of HCV positive donor kidneys in HCV negative recipients. The use of medically assisted death donations has also been advanced. There have been efforts to involve policy to integrate deceased donation in advance directives and end-of-life care plans. And the province of Nova Scotia in Canada has recently adopted an opt-out strategy for deceased organ donation. Recently in the United States, there has been a lot of attention paid to the efficiency of deceased donor services provided by different organ procurement organizations. And there is now legislative efforts to implement standardized metrics to improve organ donation in so-called low-performing OPOs in the United States. This slide shows that the discard of recovered deceased donor kidneys is a major issue in the United States. The slide shows that the discard rate is a function of transplant survival of kidneys of different donor quality as measured by the Kidney Donor Profile Index. You can see that organ discard rates rapidly increase despite the kidneys still having good survival. This slide shows that there's a wide variation in the donor rate per million between Canadian provinces, begging the question of the need for sharing of best practices to increase donation between different provinces. Finally, I would be remiss in not highlighting the need to minimize the need for repeat transplantation. The recent passage of the immunosuppressive bill, which will provide lifelong access to immunosuppressive drugs for patients in the United States who are insured by Medicare, is expected to reduce the need for repeat transplantation. In summary, there's been no improvement in access to transplantation in North America over the past 20 years. Most of the progress has been to minimize disparities among disadvantaged persons and groups. Bold new initiatives are needed to remove disincentives for living donation and to encourage non-directed living donations. Improvement in deceased donor service delivery and strategies to improve the utilization of deceased donor kidneys for transplantation are urgently needed. Thank you for your attention.
Thank you, John. We just have 2 minutes, so I'm going to ask you just one question each. There are many, but I think we can continue that conversation in the networking rooms. Shuchi, if I can come to you, you raised the issue of misattribution of kidney disease as an important problem. What research can we do to address that?
Yeah, I mean, I think I already highlighted one of the ways that that people have thought about approaching that problem, which is to get tissue in people who we would potentially not consider for biopsy as part of standard of care. So the Kidney Precision Medicine project in particular is attempting to do that, to help understand what fraction of diabetic kidney disease, for example, is misattributed and has a different diagnosis or a different pathway of injury.
Thanks, Shuchi. To John. John, you made a very shocking and sobering statement that there have not been much improvement in the donor rates in the last 20 years. So do you have any advice about what we can do? And there is another question from the audience is, do you think the focus on disadvantaged populations for access to transplantation should be undertaken given the poor outcomes on dialysis?
Yeah, the two questions there. I think that, the lack of improvement in the last 20 years is really a gut check. We need to do two things. Number one, we know that the donor population is aging. We know that the outcomes are inferior compared to an optimal deceased donor, but those kidneys are still very viable and can provide years of freedom from dialysis for patients. And we need to understand the patient's perspective in terms of what is and what is not acceptable. Right now, we have a paternalistic, doctor-centered view in terms of what is an acceptable organ. We need to understand the patient's perspective and use those safely transplantable organs where possible. On the living donor side, there's been a lot of talk about payment for donors. We still have a big barrier in terms of just financial neutrality for living donors. So I think we can, these are real barriers to donation. People's job security, certainly during COVID, are a major issue. Ensuring protection of donors and that they're not out of pocket is we have a long way to go towards that in North America. So I think those are lowbrow issues. I think the more controversial issue really is for disadvantaged patients. In my country, Indigenous people come forward as potential living donors, yet because of health concerns about potential living donors and the lack of science, ability to predict long-term outcomes in living donation, often it's not achievable. We should be, bold enough to say, should these disadvantaged patients actually be given a priority, particularly when there is efforts that are made within their families and their communities to try and identify donors, but it's just not possible. I think those conversations are necessary at this point in time. We just haven't had the courage to have them yet. Thanks, Beck.
Thank you, John. We've just run out of time. So thanks, everyone. Thanks to the audience and thanks to the speakers, of course. Let's head off to room number 6, where the next session on COVID-19 and kidney care, what happened to who and where, is just about starting. And we'll continue to network in the Global Kidney Policy Forum room. Thank you.
Welcome to our session, COVID-19 and Kidney Care, What Happened to Who, Where? I'm Miles Wolf, and I'm going to be one of the co-hosts of today's session. I'll first introduce our 3 speakers and then turn it over to them to present to you. And then at the end, my co-chair will take the lead in hosting the question and answer session. So our first speaker is going to address observations and insights from Canada. And our speaker is Dr. Deborah Zimmerman, who completed her nephrology training and her master's in clinical epidemiology in Toronto before moving to the Division of Nephrology in Ottawa. She's a past president of the Canadian Society of Nephrology, and she spends most of her time caring for patients with end-stage kidney disease. She's won the Jean O'Callaghan Humanitarian Award from the Kidney Foundation of Eastern Ontario and from the Department of Medicine at Ottawa Hospital for her track record of advocacy. From a research perspective, she focuses on in-center dialysis and home dialysis, and she's an active community member again, working with the Kidney Foundation of Eastern Ontario. She's also a current board member for the Alive to Strive Kidney Fitness Project. Our second speaker is going to present to us observations and insights from Jamaica. Ja Ho is a graduate of Institute of Medicine 1 from Yangon, Myanmar in 1990. He currently works as a nephrology consultant in the Department of Medicine, University of West Indies in Jamaica. And rounding out our speaker list and representing the United States in our North American region is Dr. J. Radhakrishnan, who is professor of medicine at Columbia University Medical Center in New York. He completed his nephrology fellowship at the Massachusetts General Hospital and at Columbia, and currently serves as the clinical chief of nephrology at New York Presbyterian Hospital. His clinical and research focus is glomerular disease, and he's an associate editor of Kidney International, in addition to being a founding editor of KI Reports. He served on multiple committees for both the ASN and the ISN. And so I welcome all three speakers, and I'm going to turn it over to Dr. Zimmerman to kick things off.
I want to thank the organizers for giving me the opportunity to share our experience with COVID-19 in Canada. I have no conflicts of interest to declare with respect to this presentation. I thought I would start by just giving a bit of background on the country, as I think that frames the context for COVID-19 here. You'll see, and I'm sure you're aware, that Canada is an enormous country with about 10 million square kilometers of land. And a relatively small population given our size at 35 million. We have 10 provinces and 3 territories, and although we have a federal government, our healthcare is actually regulated by the provincial governments, and we had tremendously different responses to the pandemic across the country. And I wanted to highlight what was happening prior to COVID-19 with respect to travel and what happened after. So you can see at the top the different airports. These are our busiest airports: Vancouver, 26 million in British Columbia, Toronto Pearson, 50 million in Ontario, and Montreal Trudeau, 20.3 million passengers in Quebec. And border travel in 2019, there were 16.7 million US travelers by car. And although our borders, especially our land border, was theoretically closed during COVID-19, we still had 22 million travelers, much of which was January to March. And you can see in those same 3 provinces, about 5 million in BC, 11 million in Ontario, and about 3 million in Quebec. And as of January 24th, 2021, this is Canada in sort of the midst of our second wave of COVID-19. We had tested approximately 17 million people, of which almost 750,000 were positive, which based on our 2016 census was a positivity of 2.13%. And of those that tested positive, we had approximately 19,000 deaths, or 2.55%. There was, as you can imagine, challenges getting useful provincial dialysis and transplant data, but I'll show you what was available. This is a map of Canada, and what you can see in the white is the population COVID positivity and the mortality associated with it in our territories and provinces. And we ranged anywhere from about 0.06% to a high of about 3% in Quebec. And similarly, there was variability in the overall mortality, again, with a high in Quebec of about 3.7%. I added a bit of nursing home data to both Ontario and Quebec, and I'll show you in the next slide why this was so important. But in Ontario, about 18% of our nursing home residents tested positive for COVID-19, with a 24% mortality. And we had even similar or greater risk of COVID positivity and deaths in the province of Quebec. And in yellow, you'll see what was happening with respect to the dialysis patient population, both the test positivity and mortality. And in those same provinces that I showed you travel, this is British Columbia, with 1.5% of their dialysis patients, this is hemodialysis and peritoneal dialysis, testing positive for COVID-19 with a mortality rate of about 6%. When we move over to the two provinces that were hit hardest with COVID-19, in Ontario at the end of January, we had about 4% of our dialysis patient population that tested positive for COVID-19 and a 20% mortality rate in those folks. And similarly in Quebec, and this is only data from the end of phase 1. I couldn't get data to the end of January. And you see for them, they had an even higher COVID positive of 6% and about a 20% mortality rate as well. And this data is hemodialysis only, as I could not get their PD data. And the reason I brought up the issue about the nursing homes unique to Canada was this tremendous risk of COVID-19 in our nursing home residents. And they accounted for 80% of the mortality in our country in the first wave. And this obviously had an impact also on our dialysis patient population. And this was a study that came out of Ontario, again, after the first wave, and showed that one of the greatest predictors of infection was, in fact, living in a long-term care residence. And then this was followed by living in the Greater Toronto area, which is one of our most densely populated cities in Canada. So that was what was happening in dialysis. This is what happened with respect to transplant. You can see this is our 2019 benchmark here in gray. And then this is what happened to our transplant activity with this tremendous decrease in activity during our first wave compared to what we did in our second wave. In the first wave, the hospitals were clearly preparing for the potential impact of COVID-19 on the general population, and living donor transplant essentially ceased, and there was a tremendous decline in deceased donor transplantation as well. And you can see that overall in 2020, we had a 20% decrease in our kidney transplantation, of which the overwhelming majority was due to a decrease in living donor transplantation at 35%. And that original graph I showed you is mirrored in each one of those provinces that I had showed you before, with the big drop off in the first wave. The outcomes for transplant recipients were pretty limited data that I could find, but this is out of the University Health Network in Toronto, and you can see in their small sample size here, about 63% of their transplant patients that tested positive for COVID-19, they were kidney transplant recipients. And of those recipients that actually tested positive for COVID-19, there was an approximate 10% mortality in kidney transplant recipients, of which the overwhelming majority was due to respiratory failure or sepsis. I was also asked to speak a bit about acute kidney injury, but there's very little data currently available, although I do know that several groups are using databases to try and define this better for us. However, in Ontario, as of January 21st, we had done acute dialysis in 240 COVID-19 positive patients, and their overall mortality was 56%. To my knowledge, there was no program that was unable to provide dialysis in spite of many chronic dialysis programs running at about 100% or more of capacity related to the fact that we were not sending people for transplant. My guess is that the cancellation of elective surgeries, especially in our first wave, may have left room for patients with acute kidney injury. So in summary, there was tremendous variability in our provincial public health responses to COVID-19. And travel, interestingly, continued across our borders, although much less after March, but really does not explain the differences in our provincial prevalence of COVID-19 positivity. The prevalence in our dialysis patients treated with dialysis very much mirrored what was happening in the general population, with the greatest impact in our provinces that had the greatest prevalence. Additional risk was associated with our nursing home residences, and the mortality, as I mentioned, in the hardest hit provinces was approximately 20%. We experienced a significant decrease in transplant activity. And for acute kidney injury, the ability to provide dialysis was mostly unaffected in Canada. And mortality was, and I put in quotes, as expected for people with acute kidney injury in an intensive care unit.
Hello, everyone. I'm Dr. O from Jamaica. Today, I will share our observations and insights from Jamaica based on our COVID-19 and kidney care. Jamaica is a beautiful island in the Caribbean Sea. We have the population of the almost 3 million based on the 2020 consensus. Among the independent Caribbean countries, Jamaica had a third highest prevalence of COVID-19. We have almost 24,000 at the end of February 2021, and mortality was 446. We've been having this significant surge since August 2020, and it's become worse in the 2021, and currently we are facing the very high surge. We have the 700 to 1,000 regular dialysis patients in Jamaica. It's mainly at the private dialysis units. And we have 5 public dialysis units. These are hospital-based dialysis units. According to the reports, up to February 2021, we had 61 confirmed death among the dialysis patients. It is 6 to 9% of the total dialysis population in Jamaica. Majority of them, they are getting dialysis in Southeast region. We have the 3 public hospitals, namely Kingston Public Hospital, and my hospital is University Hospitals of West Indies and Spanish Town Hospitals. We have Mandeville Hospital in Southern region and Cornwall Regional Hospital in Western region. They are offering the public dialysis. And up to end of February, we have 27 confirmed deaths among the dialysis patients. It is 6.6% of the total dialysis population. To compare with that, in private sectors, as usual, majority in the Southeast and Southern region, total number of the mortality is 10.7% among the COVID patients at the private dialysis units. And the highest incidence was in Manchester. It engaged with the almost 1/5 of the total dialysis population had a COVID-19 positive. We face some problems with those dialysis patients to get regular dialysis because at present only the public hospitals offer dialysis for the confirmed COVID-19 patients. And we do not have enough hemodialysis machines and maximum of 2 machines in each public hospitals. And ultrasound is not available on the COVID wards. And we have only a few number of the peritoneal dialysis patients, and a report from these patients are not available. Major problem was the staffing issue. Nursing side, doctor side, we have sicknesses among the staff, and exhaustion, physical exhaustion, mental exhaustion among the staff. And we had episodes of problems to offer regular dialysis and renal services. In Jamaica, we have approximately 4,000 of the confirmed CKD patients. To follow up them, to see them at the clinics, we had problem during this pandemic. Most clinic, almost all the clinic, we need to reduce the size, minimum 50% during the January, June to the October such. But most of us able to resume their service in November 2020 onwards, despite we are facing the huge surge in 2021. And we don't know the COVID-19 positivity rate among the CKD population, as the only limited report available at this time. But we do closely observe the acute kidney injury among the COVID-19 patients at the University Hospitals of West Indies. Up to the end of the February 2021, we had 116 confirmed acute kidney injury patients with a mean age of 61-year-old, and majority of these AKI patients are over 60 years, that is 65.6%. Only 3.4% are younger than the 30-year-old. And male prevalence is higher than the female prevalence. And 40.5% of these patients with acute kidney injury have the underlying diabetes. And very significant number, 61.2% of those AKI patients had background hypertension, and 34.5%, 1/3 of these patients had a background CKD, and they were diagnosed as acute and chronic renal failure. Among these patients with acute kidney injury and COVID-19, 44%, significant number of these patients require dialysis. 39.7% needed high flow oxygen and ventilator. 21.6% of them require inotropic support. These populations have very poor prognosis based on our observation. And 34.5% needed in ICU admission. Mortality is significantly high, up to the 33.6% among the AKI population. And complete recovery is significantly low. Only 32.8% reach back to the baseline renal function after COVID-19. This graph shows that age, gender, and mortality relationship at the University Hospitals of West Indies. We found out that the male patients over 60 years old, they have the highest mortality rate when they have the acute kidney injury. In summary, COVID-19 affected extensively to all renal services at our hospitals, dialysis units, and renal clinics in Jamaica. The prevalence of acute kidney injury is significantly high among COVID-19 patients, and acute kidney injury carries the higher mortality rate among COVID-19 patients in Jamaica. Thank you very much.
Hello, everybody, and welcome to this session on COVID-19 and kidney care in the USA. My name is Dr. J. Radhakrishnan from Columbia University. I have no disclosures. What we'll talk about today is the effect of COVID-19 on the kidneys, and also a glimpse of how we face the pandemic in terms of planning with the huge surge of patients that we experienced in New York City in the early phases of the USA pandemic. So I looked at the website yesterday. We have had almost 29 million patients who are COVID positive. And you can see the surge which happened early on that we were right in the midst of has not abated. There were a couple of surges here in July, and very recently in winter, there was a huge surge, which is the highest number of cases recorded in a day, which was over 300,000. Fortunately, it's getting better, and it's coming down, hopefully with the vaccinations. And unfortunately, the death rate also was correspondingly very high. We lost about 500,000 people to COVID during this time. And you can see the surges of the death rate is paralleling the COVID surge. And most notably, in January of this year, there was 4,000 deaths in a single day. It's coming down, thankfully. So coming to COVID-19 and kidney disease, this was one of the very first reports on the incidence of acute kidney injury in patients who are hospitalized with COVID. So if you see patients who are not in the ICU, about 16% were experiencing acute kidney injury, and about 5% needed RRT. Whereas in the ICU, it is a whole different story. About the majority of patients had AKI, and about 1/3 were being dialyzed. The overall mortality, you can see in the hospital, was 20%, with the majority being in the ICU. Our sister institution across Northwell also reported on their experience with AKI in the setting of COVID. So out of about 5,000 patients who tested positive, 37% had AKI. And this is distributed among stage 1, 47%, stage 2, 22%, and stage 3, 31%. And very interestingly, the onset of AKI was right alongside when the patients needed to initiate mechanical ventilation. And that was the single most important risk factor for experiencing AKI. And if you look at the mortality rate, 35% of these patients unfortunately died. And again, the onset of respiratory failure was a predictor of mortality. The good news, however, is that if you take patients who survive the COVID-19 illness, you can see that in our cohort of 115 patients who were followed for 54 days, the mortality was 51%. And the sickest patients, of course, with the SOFA scores that were above 15, had the highest mortality. But when you look at the overall prognosis, you can see that the gray is the patients who died. But of the patients who survived, the majority were able to come off renal replacement therapy. And the other good news is that the incidence of AKI, which is very high in the beginning of the epidemic, has progressively come down over time, despite the number of cases that are still going on. Then coming to hemodialysis patients, our very first experience with hemodialysis patients admitted to the hospital with severe COVID-19 was reported to Dr. Valeri from our institution. And here we can see the death rate was 31%. And the patients who died tended to be older and with higher levels of inflammatory markers like WBC and C-reactive protein. You can see the seroprevalence of COVID-19 across the US. This was published last year, and you can see in the quintiles, the Northeast had one of the highest incidence of prevalence, I would say, of COVID-19, varying from 9 to almost 30% in some areas. And the death rate mirrored the seroprevalence. So if you look at the highest death rates were in the Northeast and Midwest, with rates of more than 53 per 100,000 population. In kidney transplants, there was an alarming drop in the number of transplants. So there was 50% drop of deceased donor kidney transplantations. Most centers, including ours, actually placed the live donor transplantation on hold. And almost all centers had major restrictions in terms of which patients were allowed to be transplanted. And this is slowly coming back up, but there's still a lot of concern about patients being exposed to COVID in the setting of transplantation. If you look at the outcome of patients who had received a kidney transplantation, you can see the mortality is quite uniform across countries, and it's about 26%. And many of these patients actually do experience acute kidney injury. Then the most important aspect of this COVID-19 pandemic and the kidney problems that accrue from it is how to respond in the setting of limited resources. So since New York was one of the first centers that was involved, I'm going to show some in the next few slides how we dealt with this pandemic. So you can see our rates across the New York Presbyterian Hospital, which New York is one of the biggest hospitals in New York City. The number of patients with COVID-19 shot up in terms of from almost 100 to 2,500 over the course of 2 or 3 weeks. And especially our ICUs were strained. So we had to open ICUs in every possible location, including the waiting areas, with a huge strain on resources. Looking at our own service, we went from 30% COVID positive to almost 90% in a period of a few weeks. And we generally see about 125 patients as an in-service nephrology, and we went almost to 200 during the course of the epidemic. Our new consult rate went from almost 10 to 15 to about 30 per day. So every single nephrologist in the division were on site working hard to combat this. Our renal replacement therapy was the single most important point of resource limitation. And you can see we go from about 10 to 15 CRTs at a time to almost about 60 to 70. And the number of patients who are positive in the ICUs was correspondingly very high this time. So we developed a multidisciplinary crisis team with every person who's on the front line as being part of this. The entire rotation was reorganized, and as it is changed almost every week based on the volume data. So I'm not going to go into the details of this, but you can see the number of people involved in the crisis team, not only from within the division, but from industry, from hospital administration, from dialysis suppliers. We had a daily crisis team video call and in communication with not only the regulatory people, like the FDA, for example, but we also communicated regularly with industry and received advice from other centers with special expertise. We had our statisticians model the number of patients, and you can see the worst case scenario was unsustainable. Luckily, we leveled out in terms of patients who came in with COVID-19 requiring our services. One very important part of this was the development of dashboards by Dr. Stevens, and we could see at one glance, the number of patients, prediction models for how many people required CRT, what were the number of people available to take care of patients, not only in the division of nephrology, but also we had a chart showing the number of bags available that would be required. And we had to reduce the dose of CRRT, and not to waste bags, Dr. Stevens made this nomogram to conserve fluid. And you can see enterprise-wide, every hospital in our system would upload data, and we could see, right, for example, right here, 100% usage of CRT machines, and we are over capacity. So the hospitals that were under capacity would transfer their machines to the other hospitals. And the same with personnel. So there were a severe shortage of dialysis personnel, And we've had to move nursing personnel across the system to account for this shortage. Dr. Oz helped us, and in a tweet that he sent out, we have actually received dialysis nurses who are willing to help our system. This is published in Frontiers in Medicine as a manual for anyone who's interested. How about resident education and quality of life? We can see that the bottom line here is that there was worsened quality of life, and there was 15% above the distress threshold, but luckily education did not suffer. And finally, telehealth is here to stay. We can see that the number of patients who were happy with telehealth went from 11% to 76%. And in fact, the majority of providers, including myself, are very comfortable now using telehealth. And it's only going to grow. And fortunately, the Centers of Medicare and Medicaid services are now reimbursing this and will hopefully do so in the future. Guidelines are available at multiple sites based on our and other people's experience. And I thank you for your attention. I will be available for questions.
Okay, great. Well, thank you so much to all the amazing presenters and your insights into what's been happening in your local regions. Certainly very, very relevant to today and going forward. There's been Sorry, I got muted. There's some good questions in the chat, so we will, I'll propose those questions and would love to kind of have your input. We're a little bit short on time, so if we're running long, I'll adjust from there. So the first question is for Dr. Zimmerman. A lot of questions focused on the nursing home information that you gave. So I know that you flagged that uniquely to Canada, and a huge proportion of fatalities in the first wave were in nursing homes. Can you kind of give a little bit more insight into this, or explain, or your theory, what might have been the cause?
So there's been lots of look in the different provinces about what was happening in our nursing homes. And I think that it was very likely a reflection of a process and that had actually been starting well before the pandemic. But the difficulties that were there were clearly exposed by the pandemic. And part of the issue may well have been staff that were actually trained to be able to deal with this type of situation especially early on, when there was not enough PPE in our nursing homes in order to protect both the residents and the staff. And many of the staff actually worked in multiple residents, so they would potentially go from one resident, one nursing home resident to another. And then when you think about the environment of some of these nursing homes, there was also the inability to self-isolate individuals when they're living in often this very group sort of centered environment. And I think that was part of the issue, and there certainly needs to be an ongoing reevaluation about how we support our most vulnerable folks as we move forward.
Yeah, absolutely. Thank you for that. Dr. Ho, next question to you. Are there any changes in approach to COVID-19 in Jamaica with the next wave or coming waves, if there are some?
Thank you for the question. Of course, we did changes and we see some improvement. At the beginning of COVID-19, we had difficulties to get some baseline results, including the renal function test results. So some of the patients, we diagnosed advanced renal failure at very late stage. But after that, we could diagnose renal injury on all admitted patients. We observed on them, and now we found out some risk factors associated with mortality, and we've been trying to correct it. And although the number of the COVID-19 and daily cases increasing in Jamaica, I observed the number of the renal injuries declining in this time because we got early detection of the renal injury, and we could focus and correct on some modifiable risk factors like hypovolemia, hypotension, concomitant sepsis, and limitation of use of the inotropes. So, of course, definitely we are trying to improve, and we are seeing some positive results this month. Thank you.
Great, thank you so much. Dr. Radhakrishnan, a couple questions coming for you. One is essentially, is there anything different in the approach to the COVID-19 in the second or third wave with the US currently? And then more specifically, they said, were you guys using acute PD in any patients, as NYU presented their cohort data of PD in prone patients yesterday? Any thoughts on those?
So the first answer to your first question is that we are seeing a very sharp decline in AKI rates amongst the hospitalized patients with COVID. It might be that people are getting dexamethasone or remdesivir early, and there's more attention to volume management. So we're not quite seeing the same incidence rates of AKI. So that's one, and that's good news because we have a backup plan that's ready to roll the moment the numbers on our spreadsheet achieve a critical level. And the second is peritoneal dialysis. It's very institution dependent, and thus far, the reason why we, at least in our institution, didn't go towards PD was because we still had enough supply of CRT machines and equipment. So we didn't need to introduce another procedure, especially it gets a little tricky in terms of volume management in patients with high FiO2s. So other institutions did do it, and they were quite happy with it. But at our institution, we didn't have to resort to this.
Okay, perfect. And then Dr. Zimmerman, just a quick question. Any experiences with urgent PD in Canada?
So interestingly, it's funny how things come full circle. When I trained in Toronto, Mark Goldstein used to insist that we use acute PD in the ICU. That's probably dating myself. But to my knowledge, and of course, I really don't know what's happening in all of the different hospitals. Our own hospital has not used acute PD during the COVID-19 pandemic, but there's certainly enough expertise across the country that it could be done, and there may be units that have used it, perhaps in the GTA, in the Toronto area, that I'm not aware of.
Okay, perfect. So we're kind of running to the end of time. There's some great questions in the chat. Please continue to send them. ISN will compile everything and we will send the answers out on social media. And thank you again to all the presenters for your time and for the amazing presentations and for taking the time to be here live and answer our questions. Just a reminder for everybody, there's a session right after this, and so you'll need to kind of close out of here and then exit to room 4 back into the mainframe, and you can come on that way. Thank you again for joining us. Thank you, Miles, and everybody, and we look forward to hopefully seeing you all soon.
Thank you.
Welcome to the closing remarks and next steps. And I want to acknowledge with much gratitude that I live and work on the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And many of you come across this country from your territories and wherever you are in the world, from places long and wide. I think this has been a remarkable global policy forum where we have managed to get together across a vast region with diverse perspectives. We had an opening session that set the scene with WHO perspectives, Sustainable Development Goals, and the Global Kidney Health Atlas in general and in specific with respect to this particular region. And then we walked through Canada, the Caribbean, United States, looking at quality, sustainability, and equity of access to kidney care and services. And I think a number of things came to me, Vivek, as I was, listening and thinking. First of all, that the recurrent themes about education, inequality, vulnerability, the need for humility in the way that we approach patients and our healthcare systems, the fact that racism exists and disparities in healthcare exist no matter how high the income of the country is, and that the diversity across the different countries and within the region and within the regions like the Caribbean was really quite remarkable. The theme of language came up, and it's not just language to speak to policymakers and patients, but even languages across the different countries is really important for us to think about. The economic burden of kidney care and healthcare in general, and the importance of governance of structures, whether it's to address a pandemic or non-communicable diseases, came across quite profoundly as well. I was interested in the Caribbean to think about brain drain and how people are moving out of the Caribbean, and they need the resources of the people that are being trained in the things that they're doing in the Caribbean to address that. The bias in healthcare that is evident everywhere, I think is another thing that we need to think about in terms of when we policy. And that we need to continue to have scientific curiosity and perhaps marry research, science, care, and policy so that we understand kidney diseases better. It struck me as Dr. Anand was speaking about the need for curiosity as to the cause of kidney diseases, that in our Indigenous populations in Canada, we often ascribe the kidney disease to diabetes or hypertension, and yet it probably isn't. And maybe we should take lessons from the US. It took them a long time to figure out about APOL1 gene. Why can't we think about this within our own communities as well? Access to care was another important thing. And I think the patient stories, both from Glenda and Marie Bocage and others that were represented, were really important for us to listen to. And the disparity between prevention, identification, dialysis access, and transplant access, and sort of innovative ways to think about this. And then lastly, the last session on COVID-19 and kidney care, which really just highlighted all of the problems of kidney care and probably just magnified them. And in the kidney world, perhaps to Sir Alan's opening remarks with respect to our need to agitate and advocate, perhaps COVID-19 is our platform. It is our time to actually really, really bring to the fore kidney diseases in a way that we haven't been able to before. And so I think it's important that we remember that we started this policy forum with the 12 recommendations that we generated back in 2017. And I think they're all still very relevant about looking within frameworks, thinking about the public health policies that exist, how you educate your workforce and patients in a language that they can understand, and how you integrate evidence-based treatment and curiosity. These are all important themes, and I would ask that all of the people attending the forum today perhaps go forward and go home, or stay, because most of you are staying home, but go back to where you came from and ask yourself whether you understand the disease as well as you should. If you do have registries so that you can pivot in a pandemic and understand where resources are or should be, like what do you have and what do you not have that you could take this forward to. So those are and I guess in the very Indigenous way of thinking, one of the phrases that Evan Adams has used in the past, which I quite like, it's that gathering wisdom. And perhaps these global policy forums are just that. They're a place to gather wisdom, share it amongst ourselves, and then go forward. So with that, maybe we can have a bit of a conversation about your thoughts from your part of the world in your different time zone and space, and your reflections.
Thanks, Adira. I think you've captured the essence of the several sessions that we've had quite well. I wonder, what are your thoughts about, we have now done 3 versions of this policy forum. The more we go around the world, the more it seems things have some variation, and the flavor changes a little bit, but I think the basic thing remains the same. Whether it is India or it is Southeast Asia, where we did it last time when we were in Melbourne or in Mexico City. So there is local flavor, but I think the essence remains the same. You work in Canada, of course, which is classified as a high-income country, but within Canada also you invoke the First Nations right in the beginning when you spoke, and there are populations that we recognize which are disadvantaged. So oftentimes we use terms like race and ethnicity in a very unthinking way. What is your thought about the role of identity and status and the intersection with race and ethnicity, etc.? So, who gets what? And what is identity, what is status, and how does it intersect with their ability to healthcare? If you look at ability to get healthcare from that angle rather than just the race and ethnicity angle.
Wow, that's a big question, Vivek. I think we are all citizens of the world. I think all of us deserve care. And I think that, yes, identity and race gets mixed up with other things. I think that, as was spoken about at the very beginning in WHO, and then Evan Adams also, I think it's about seeing people who they are in their moment and making sure they get the best care possible. I one of the things I thought you're going to ask is, how do these global policy forums change what we do? I might suggest that in our conversations in preparation for this, the fact that we could have a global policy forum in 4 hours doesn't do problem justice. And so perhaps each time there is one, the legacy is that we need to take the learnings from this and now make sure that our policymakers in Canada, the US, and the Caribbean hear again and amplify this message. And the notion of identity is maybe it's people living with or at risk for kidney diseases. And the key word here is people, right? And it's plural, and it is across all different socioeconomic status. But I think perhaps identifying people at risk is one of our key things that we need to do. And also, I think other speakers have also talked about this, but educating people so that they're curious about what could be affecting them so that they're actually part of the solution generation. There's no question in my country that people listen to doctors who look like them more than they listen to people that don't look like them. And so making sure that we have fellowships and scholarships that are equitably accessible to all different walks of life is also important. And I think a few speakers spoke about the need to educate locally. And I think that really will go a long way. But it would be nice to have a Canadian, US, Caribbean forum, dedicated with the policymakers in the room so we can actually hash out some solutions, not just talk about the problem.
Yeah, thanks. So the point I was trying to get to, I guess, is related to some of the other things that you also mentioned about the issue of gathering wisdom. And although we heard a lot of data, but I think for us to be able to make a difference, and you raised the issue of what do these policy forums do. So if now that we have at least the fundamentals of what people think around the world, the gathering wisdom perhaps now requires some new ways of storytelling, which people can use. And ultimately, as you said, it needs to be a groundswell of support and more of a bottom-up kind of movement for us to be able to go to the policymakers. We do recognize that policymaking is a somewhat different beast compared to just doing research and generating evidence. And that was perhaps the thought behind what George Allen said about agitating, demanding, and an issue of using the right language and so on and so forth. So what are your thoughts about that, those approaches that we need to take perhaps going forward?
Well, I think, agitating and advocating is one. I think making sure that the patients are with us. I think it's not going to work. HIV and other diseases made a big impact by having patients at the center. We talk about it, but we haven't walked the walk quite as well as we should have. And I believe that with patient stories and patients at the center and them talking with us to policymakers or without us even will be a huge difference in the way that we change the way that people think. When people, and it's about seeing yourself in those people. So you bring the diversity of your country or region to the policymaker and say, see all these people, they all have this disease. They look just like you and me. and we need to fix this. And I think that's a different way. And I think never letting up. I think that's what George was also saying. You know, you don't stop. It's not every day is a day for kidney health. It doesn't have separate days. So I think those are some ways to change it, but just the groundswell, as you said, is going to be really important in this region.
Right, and we cannot get away, without talking about COVID-19. And we have often discussed that what COVID-19 has done is to really bring the healthcare conversation front and center around the world. And the challenges faced by patients with non-communicable diseases, including patients on dialysis and so on, have been highlighted around the world. Even in countries with very mature healthcare systems, I think the tragedy of dialysis patient dying has not escaped people's notice. So what can we do as a community to make sure that we are in a position to make some of these lessons stick? We talk about preparedness and we talk about resilience. Is there a moment here that we can latch onto? And that might also be linked to maybe making the patients our allies.
Yeah, it's a great question. I think there's, COVID-19 is always the preamble and then the kidney part afterwards. And maybe, we have to flip it and call it kidneys and COVID-19, not COVID-19 and kidneys. I mean, that might be a start. Just reframe it so people are listening to what we're telling them. So it's more about how do you actually ensure equitable access during any kind of public health emergency for people living with and at risk for kidney diseases. And the consequences of not paying attention ends up being a tragedy with respect to economics, as well as families, as well as everything else. So it's a huge issue. I think we need to seize the moment.
One more point, I think during the conversation, there was discussion from the KHI about precision medicine and so on, the big initiatives that are going on in US. But when we think of populations and when we think of inequities, perhaps there is a case also to be made for non-precision medicine, but population medicine, but where we may not always be that precise, but we get to the large number of people that we do. It's not a binary situation, of course. It's not to suggest that those who advocate this are against precision medicine. We all want that progress also to take place. But I think there should be some initiative similar to the precision medicine initiative that also at the same level propagates a population level approach. And I think there are conversations from the WHO and UN about taking the whole of society's approach and whole of government approach. And this might be a moment, given the fact that as kidney doctors, we are perhaps least quote unquote specialized amongst all the other medical disciplines. We might take the lead there.
Yeah, no, it's right people's right treatments at the right times, and it's plural. And maybe that's the approach. And I think you're right. It's a continuum from precision to population and back again. And it's that interaction of genes, environment, and other things that we need to understand. But you can understand that with populations, not just with individuals, and maybe helping to see people that were more pluralistic in our way of looking at things, whilst not missing the opportunity to understand individualized care. And I think that's the balance. And the problem is the more complex you make the message, the harder it is to implement. But so we will find that balance. And that's perhaps one of our challenges over the next little time.
Yeah, I think we are coming towards the end of our time. Do you have any last minute reflections, Adira? About next steps possibly?
Next steps, I think, is for people to not think of this as a session at a World Congress, but rather a way to reframe the way you think and do the work that you do, whether you're a researcher, a clinician, an administrator, or a patient, or someone working in the kidney-related industry. I think we need all of us to take this and figure out what we're going to do differently tomorrow. Not just that we came for 3.5 or 4 hours together to learn about each other, which is also super valuable, but what are we going to do with that knowledge, right? So we gather the wisdom, but then we also tell the story.
Thank you. Those are perfect words to end this long and very, very enriching session with. Thank you, Adira, for your leadership through the years. And thanks to all the speakers and all the participants who have joined these different sessions, switching from Zoom room to Zoom room, but sticking to the message that we are now changing our conversation from kidney disease to kidney health. And that's something which we need to do as a global community. Thank you. Thanks, everyone. And we'll meet again in 1 year's time.